want me to wait? Who is? Good morning. Good morning, everybody. My name is Ger Shaw. I'm the Nursing and Midwifery Services Director in the Office of the Nursing and Midwifery Services Director in the HSE, and we commonly use the acronym ONMSD. So if I refer to ONMSD, you know what I'm talking about. I'm delighted to be here as your chair for the first session this morning. Thank you to those that are present here. It's lovely to see people in person and to see people's faces, you know, which we've missed for so long. So there's 180 here present this morning in the hall, and online. Welcome to those that are online as well. So my understanding is there's 235 logged in online at the moment, so that's very welcome, and you're all very welcome to the inaugural Deteriorating Patient Improvement Programme Conference. Before we begin this morning, some housekeeping. So in the event of fire, a continuous bell will ring. Please evacuate the hall. I'm a bit like a Ryanair hostess at the moment now. So there's emergency exits on the left-hand side and the right-hand side of the hall, so evacuate through those doors. Please silence your mobile phones. The Twitter handle for today is DPIP Conference 2022, which you'll see up here on the poster in front of you. In the interest of efficiency and time this morning, the agenda, which is placed on your seat, has a QR code both at the front of it and at the back of it. And if you can scan the QR code with your mobile phone, this will take you to the link for the conference website, which contains all the material, and it contains all the bios of all the presenters this morning. And as well as that, the presentations from today will be uploaded on the website later on. And I'm also asked to remind you on the website, if you can fill in your evaluation forms, that would be great. We begin this morning with a colleague of mine and an ONMSD member of staff who has a nursing leadership background in acute and emergency medicine. and who I've been delighted to support and has done tremendous work in her role as the national lead for the DPIP programme, and a lot of successes have been added to her belt. She has really driven this programme, and I am delighted to welcome to the stage Aveline Casey, who will do the welcome and launch this morning.
Morning, everybody. I'd just like us all just to take a minute and to just really absorb and enjoy the atmosphere of all being together and celebrating together, you know, what we've achieved, what we're going to achieve, and just enjoying one another's company face to face. It's fantastic. So thank you all for coming this morning. Please make sure and talk to somebody you don't know today, because you never know what you might find out. And that's the key thing to do. Don't stay with the people you came with. Go meet somebody you don't know. Okay, so the first slide. I suppose I want to take you just a little bit on a little bit of a journey. I suppose my personal journey with this was way back when I was Director of Nursing in St. Luke's in Kilkenny. I read an article about early warning systems, and there was 2 SPRs who were looking for a research project, and I begged them to introduce a muse into the medical assessment unit, as it was at the time. So they went on to write a really good paper. John Croke and Joe Gallagher were their names. They're 2 GPs now. And that was the start of my journey with early warning systems all those years ago. I won't tell you how many years ago, because you'll just know how old I am then. But I suppose that was the start of my journey. Went with acute medicine. With Ailish Croke, we developed the first NCEC guideline, the National Clinical Effectiveness Committee guideline, number 1, news number 1. In 2017, then Geraldine kindly asked me to chair a steering group. And out of that, they didn't know what they were doing, because out of that, they got a whole programme. You know, so we went from steering group to programme. So I suppose, you know, and on that journey, there's been an incredible amount of learning. And I suppose where we've come from now, from an observation chart and a score, we moved right into a whole system. And that whole system is there, that whole anticipation, recognition, response, governance, and then education in behind that. And it's a huge achievement, because what we've actually done, if you think about it, is we've created a whole paradigm shift. We've moved from chain of survival, which is your CPR piece, to actually now trying to prevent that. So we're trying to move away from that. We're trying to look at earlier intervention, prevention. So in terms of the programme, our big, hairy, audacious goal is to eliminate, and I make no apologies for eliminate. I was asked numerous times to take the word eliminate out, but I don't think you can seek just to reduce. If you say eliminated preventable deaths, how could you just want to reduce? You want to eliminate. That has to be the hairy, audacious goal of what we're all trying to do here in this room. So that is what we're trying to do. That is our BHAG for the programme, is to eliminate preventable deaths from unanticipated cardiac pulmonary arrest in non-pregnant adults in acute hospitals. Big long mouthful, but that's what drives me, that's what I think about, that's what all the people who work on the programme with me are passionate about, and that's what we all think about. I do want to at this time acknowledge somebody who is very key, who's not with us today, but Dr. Miriam Bell, who led the guideline development project. And I suppose the guideline, and we have lots of international interest in it, is really a credit to all her work and all her perseverance. And we had lots of debates, and I suppose you'd call it maybe rows about different parts of it, but I think it has stood. The adoption of the guideline has been pretty smooth, so I think it has stood its time. So I really do want to acknowledge Miriam for that. And there are other people to acknowledge too. Serena, who worked on the quality improvement and who's here. Ronan, who worked on the education piece. And now we have a new team that are coming on board. And you'll know them from their sepsis work. We have Mary Bedding. Stand up, Mary, and say hello. So be sure and talk to Mary today. Yvonne, who's beside her, also stand up. And the fantastic programme manager that I'm absolutely blessed to have, who keeps me in order, who keeps me working, keeps me ticking, Blanet, stand up. And Blannet has single-handedly organised everything that's happening today because I took last week off. So that's, programme manager there. But anyway, I digress. So we'll go back to where we were. So what we have now, we don't have a score, we have a system. What we have is a big, hairy, audacious goal, a big patient safety goal that we're trying to achieve. What I've learned, sorry now. Go back. Okay. So what I've learned, there's a data slide that I was hoping to put up there. I've cleansed the slide a bit so it doesn't give you exact details because I want to share. But what I've learned is language is very important when you're trying to drive something like this, like a big improvement, a big change, and you have to be very cognizant, you have to involve people, and you have to be careful how you approach things. The other thing that's really, really important is data. So there can be lots of data out there, but there's not a lot of interrogation of it, or it's really difficult to get. But you can't know what you're improving or that you've achieved any improvement if you don't measure and if you don't know where you are. So I suppose on our slide, on our data slide, I don't know whether it'll come up on the next one and I can go back there. So on our data slide, what you see and what I've learned is we know that there's variation in what's happening in terms of unanticipated cardiac arrests. We know there's seasonal variation. We know, based on that data, that we have a rate of 2.3 per 1,000 discharges. Most other countries collect their data on admissions. We don't have admission data. On discharges, you would have less. Your lower will be number because you're not capturing everybody. And we know that's from HYPE data, so that's as dependent and as good as your coders are. So what I'm saying is we have data, but we don't really know what we have. But we know unless we do something different, we're not going to do something really radical and different, we're not going to improve that. So when you look at that 2.3, that translates to about 900 unanticipated cardiac arrests per annum. Now that is a gross underestimation, I believe. I can't prove it, but I believe it. And 400 of those people die. So to me, they are, they're preventable deaths, quite a significant number of them. Some of them should have been on maybe an end-of-life pathway, and we'll hear more about that today. So it's really important that we start thinking about this and we really start looking at our data. And that's one of the key pieces within the guideline is governance and about how do we look at our own in-hospital data. How are we going to know what we need to focus on and what we need to improve? And the interesting thing about that data there, and the only annotation that I left on it, was the dip. And the dip was around COVID. Now, I think that's fascinating because I would have assumed that you'd have patients who would be sicker, so your numbers would go up. So I'll proffer this to you, that during COVID we had sicker patients. We mightn't have had as many, but they were sicker. They were all cohorted, which is interesting. I would always advocate for cohorting different diagnostic conditions. We had team-based medicine, so we had teams staying on the ward, so they were available, and we had anticipation because people were expecting people to deteriorate. So you would have to proffer and wonder, was that what happened there? Do you know what I mean? And is that how we should be progressing? Is that the big change we need if we want to change that number? I could go on all day about this, so I'm not going to because really we have a full schedule. But if I go back to the other slide, I suppose the other slide that was up here, I just think, 1.7 million inpatients, that's what we're talking about here. That's how many inpatients are affected by iNews. We have 35,000 staff that every day use iNews. We now have, when we were doing some of the focus groups, some of the junior doctors, well, what did you have before iNews? Well, we had OBS charts and they were looking. So there's a whole generation of staff who have worked with only news, iNews. They don't know any different. So that's fantastic. We have it in all our hospitals. We have a standardised approach and standard to what we have. We are so blessed to have that. We need to kick on, move on. I really hope you enjoyed today. I really hope you see what we're trying to drive and what we're trying to move on. In terms of digital iNews, in terms of anticipation and safety huddles, in terms of our critical care outreach. These are all the big change drivers. And of course governance and of course audit and how we're looking at that. So I hope you enjoyed the speakers. I do want to mention the chairs today. So Geraldine has introduced herself. She's absolutely fantastic support to me in terms of this programme. She goes way above and beyond really in terms of funding and supporting us. We'll have Mike O'Connor, who's a National Clinical Advisor for Acute Hospitals, who will chair later on this morning. And then in the afternoon, we have Maria Lorden-Dunphy. Both of them are absolutely fantastic supporters of the programme. Maria works in the National Quality and Patient Safety Division and has worked with me in QI in terms of looking at different projects, and some of the speakers, Liz, will be up later on to talk about some of the work that we did in Mayo with QI. So it's fantastic. Enjoy the day, that's the main thing, and look forward to chatting to you all later. Thank you.
Thank you very much, Evelyn, for that. So we're going to keep moving, and our next speaker is Dr. Orla Healy. Orla has a background in both public health and hospital medicine. She's also occupied a range of senior management roles in the services, including Director of Quality, Governance and Patient Safety, Director of Strategy, Planning and Population Health, and Chief Operations Officer. So she's a broad broom under her. In April 2021, she took up her current role, which is the National Clinical Director of Quality and Patient Safety in the HSE. I now invite Orla to give the opening address. Thank you, Orla.
Good morning, and thank you, Geraldine. And I am going to say what every speaker is going to say today. It is absolutely delightful to be in a hall gathering after 2 years of lockdown and various restrictions. So thank you all for attending physically, and thank you to our colleagues online. Another one of the benefits of COVID, we get this blended approach where we get the benefit of being present and being at home and sharing all of this wonderful learning. And I hope you'll use the opportunity to learn from the expert speakers throughout the day, but also to learn from each other and use the fact that we're together to build on your own expertise and to share what you know with others. So, as many of you will know, it's June, it's State's exam season in Ireland. And for those of you who are not in the zone, yesterday was science, Junior Cert Science. And I happen to have a Junior Cert Science student who, waning on Saturday afternoon, decided that he would get his mother to do some of the work and ask him some questions. So, first year biology, first question I came upon: what's a cell, what's a tissue, what's an organ, what's a system? Now, it's a tenuous link, there is an analogy here. It's not akin to Father Trendy or a bad sermon, but a tissue is a collection of cells. An organ is a collection of tissues. A system is 2 or more organs working to deliver a function. The best functioning healthy cell cannot deliver on its own, and no system can deliver without functioning cells. It's the same for quality improvement. So quoting our colleagues in Cambridge who published in the BMJ last year, a systems approach to healthcare improvement is a way of addressing health delivery challenges that recognises the multiplicity of elements interacting to impact an outcome of interest and implements processes or tools in a holistic way. And we know from our lived experience, and we probably know it intuitively anyway because we're that way minded, which is why we're here, that a systems approach to improvement delivers better services and better patient outcomes. So I am going to quite shamelessly use the opportunity to describe the systems approach to quality and patient safety in the HSE this morning. So the systems approach isn't new to the organisation. a lot of you, I certainly remember audit offices in the hospitals back in the day, but at corporate level, and now Maureen, I used the word corporate, she said, say centre, don't say corporate, people don't like corporate, but the fact is we are corporate and we have a corporate entity for a reason. It's here to enable. And at a corporate level, we've had that systems approach since about 2008 in one guise or another. So it would have started with a safety incident management teams in response to incidents like Portlaoise, then you remember Mary Harney's time. Then in around 2012, that function split, well earlier on it split into clinical programs, separating from the pure quality and patient safety element of it, but again two sides of the same coin. Subsequently, patient safety and quality improvement would have split between quality assurance and verification, which was the stick side of the house, and the carrot side of the house that was quality improvement. And then last year, there was a recognition that it was one and the same, and quality improvement should be driven by patient safety. So we merged again to form the Quality and Patient Safety Directorate. So the purpose of that directorate is to work in partnership with our colleagues in operations and with patient representatives and other internal and external partners, because I refused to use the word stakeholders, to improve patient safety and the quality of care. And we do that through various teams. And these are our teams. They are QPS, the Patient Safety Programme, QPS Improvement, QPS Intelligence, QPS Incident Management, QPS Education, QPS Connect, and the National Centre for Clinical Audit. I will briefly describe each of them because each of them has a relevance to your programme and to your own areas of interest. At the outset, I'm going to call out patients as partners. So our management team includes 2 patient partners. That is evidence to our commitment and HSE policy to involve patients in the design and the delivery of healthcare. It's because we're committed to patient-centeredness, but it's also born of a level of self-interest, and there are many benefits that accrue. The voice of the patient is sought and heard, and it keeps us grounded in the reality of how the system is working from their perspective. They attend our management team meetings, they're involved in decisions from the outset, they have access to the full agenda. Within the teams, they're involved in our QPS training, our talk time, our National Open Disclosure Steering Group, our National Centre for Clinical Audit Steering Group, and various working groups throughout the Directorate. We have found it hugely beneficial and would encourage, as per HSE policy, that patients, advocates, representatives are included from the outset and throughout. So just moving on to the various teams, and everything, all of the teams are in line with the patient safety strategy and grounded in it. We're, as a directorate, we're anchored by patient safety. So the design and the delivery of everything that we do is as outlined in the strategy, the 6 work commitments and the 57 implementation targets within it. That strategy was published in 2019, and like a lot of documents published around that time, it was impacted over the course of the pandemic because of the redeployment of staff. But we're back in business, implementing the strategy, guided by the Patient Safety Programme, whose job it is to oversee and monitor the implementation of that strategy. They're currently establishing the governance structures and the processes to do that, but they're embedded in all of the other teams throughout the Directorate. Safety commitment 4 in that strategy is to address the major causes of harm. And there you are up in lights as one of the major causes of harm in the system. The biggies being healthcare associated infection, medication safety, but the deteriorating patient is up there in lights internationally and here in this country. So the specific principle there is that health and social care services will implement best practice for patient safety, incorporating safety improvement methodologies to achieve a measurable reduction in patient harm in prioritised safety areas. The actions associated with it include all of the actions in place for the Deteriorating Inpatient Programme. Our QPS improvement team use improvement methodologies and practice in order to address the common causes of harm as outlined in the strategy. So, question often asked, why do we have an improvement team? Why improvement methodologies? Well, it's because they work. Things don't happen by chance. Things don't happen without a movement or a method. And the framework, for instance, provides a useful, and that framework is, that toolkit is currently being updated, but it provides practical tools to support the implementation of quality improvement initiatives. So there are 17 practical tools, and it takes you through from kind of the light bulb moment of the inception of an idea right through to the sustainability plan, where you're embedding the improvements that can be achieved. That team also collaborates with the Royal College of Physicians on the postgraduate cert in quality improvement and leadership, and indeed other educational initiatives that many of you will have been involved with. So the next team, which again is at the harder end of the patient safety agenda, is the incident management team. The core functions within that team are the policy development, i.e. the incident management framework, which was updated last year and is continually undergoing review. And the review at the moment is very heavily focused on Just Culture and the Just Culture Guide. For those of you who are not familiar with the Just Culture Guide, it's something that comes up repeatedly, and repeatedly in the context of our efforts to learn as an organisation, to report, to review, to learn. Accountability is a recurring issue. I am attending the Safety and Quality Committee of the board today. I've just come off a discussion about public accountability and getting the balance right between investigating, reviewing, learning, and being publicly accountable. Very hard. Patient safety investigations are conducted for the purposes of learning. People participate in them freely and openly with a view to sharing, to being open about their about events and experiences and sharing that learning. So therefore, we need to protect that space so that we can learn in the whole accountability arena. And the way we do that is using the Just Culture Guide. So we do not have a no-blame culture. We have a just culture. So where issues of accountability arise, they're dealt with, whether it involves reporting to the guards, reporting to a regulator, reporting to HR, addressing things through those policies, so that that happens separately and in parallel to our own investigations and reviews that we learn from. So that's the framework and the Just Culture Guide. And the other two areas that that team deals with is open disclosure. Open disclosure, again, to the forefront at the moment as part of the Patient Safety Bill, which has just been through the fourth stage, committee stage of the Dáil, and will be into law very shortly. And they also manage the National Incident Management System that many of you will be familiar with. Touching on Evelyn's slide and the measurement, and so we have a QPS intelligence team. Depending on who you listen to and what you read, measurement and surveillance is seen as a sort of a bureaucratic, self-serving entity, but we are very firmly of the view that what can't be measured can't be improved. So this intelligence function, whereby we analyse, interpret, present quantitative and qualitative data to inform better decision-making and drive improvements, and enable others to generate their own data to do likewise. So the examples of the work that team does are the development of a quality and patient safety surveillance system, the COVID-19 report that many of you will have received over the course of the pandemic, the quality profile, or a piece of work that many of you may have participated on following the cyber attack, where we did a mixed method analysis of the effectiveness of the patient safety risk mitigation strategies during the cyber attack. They're also involved in a lot of research, but I've just got the 5-minute sign, so I had better move on to the other teams. Not forget our colleagues in QPS Education. Education central to everything, coordinating and development function that has delivered most recently a prospectus outlining all of the quality and patient safety education material available within the system, in person and online, and that ranges from incident management training, systems analysis training, open disclosure training, quality improvement methods, audit methodology, and right up to the certificates and diplomas and human factors training that's delivered by external parties for us. We're also developing a QPS competency framework. So our vision for the QPS competency framework is that everybody within the organisation at every level would be competent in quality and patient safety, appropriate to the level that they're functioning at. So the porter bringing the patient to theatre knows when to disclose an issue and the level at which they disclose, so that the multidisciplinary team, the clinical nurse specialist and the consultant who are part of a patient safety incident, know how to deliver open disclosure, so that people who want to institute a quality improvement programme are equipped with the improvement methodologies and know how to deliver it. So that is the vision for the QPS competency framework that's being developed. Next team, and recently established, is the National Centre for Clinical Audit. That is the centre that will be supporting and promoting the in-hospital cardiac arrest audit proposal in this year's estimates. So that group, again, in response to a 2019 report, saw the establishment of a centre whose role is to, sorry, I've gone a slide ahead, that's because somebody flashed the 1 minute. I'll just, have I time to breathe? So that centre is implementing that review. So we've done a lot of work on the national governance of audit, so setting the criteria for commencing an audit, the criteria for stopping an audit, setting the strategic direction for national clinical audit in this country, but also supporting local audit and the local governance of audit. So the audits you do at the front line, and we're trying to link those audits to quality improvement methods, because audit is an improvement methodology, but audit of itself is just a measure without the improvement to accompany it. And the last slide, and very importantly, is QPS Connect. This is our internal communications plan, but it is evidence in action by our hub outside, which you're all invited to drop by over the course of the day. And I actually think that I am on time, because that's our Twitter handle and our website and our links. So thank you all for your attention. Please visit our sites and log on and use the supports available to you in your own quality improvement journey, addressing one of the major causes of harm in the system. Congratulations and thank you.
Thank you very much, Orla. That was very informative. And just before I introduce our next presenter, I just want to say that all the speakers from this morning are sitting up the front. So I know we're doing the surgeon major approach and keeping everybody to time to keep things moving. But should anybody want to have a word with anybody, you know, they're all sitting up the front. So feel free to do that at the coffee breaks, you know, as appropriate. And all the material will be on the website, as I said, and don't forget the QR code that's on your agenda that you can link into for all these very, very useful documents. Our next speaker this morning is Dr. Dorothy Breen, who is a specialist in intensive care medicine and senior lecturer in the Graduate School of Healthcare Management at the Royal College of Surgeons in Ireland. She's currently leading a HRB grant investigating the impact on patient outcomes of simulation training to proficiency for safety huddles. And Dorothy is going to share with us this morning her perspective on safety huddles. So I invite Dorothy to the podium. Thanks, Dorothy.
Well, good morning, everybody. And first of all, to extend my thanks to Evelyn and the team for inviting me here. And it really is so encouraging to see the movement building around all this work around the deteriorating patient. As many people know, I've been on this journey for a long time, and it really now is gathering momentum. So that's really nice and good to see. So I'm going to talk about the safety huddle, essentially. And, you know, it's being pushed now by various healthcare organisations and safety bodies around the world, in America, the US, NHS, Australia. And I suppose I'd just like to ask you first, just maybe a show of hands, around how many, or if in your organisation you do a huddle of any kind. Just put up your hand. It's very good. Now keep your hand up. And if it's a safety huddle as opposed to an operational huddle, keep your hand up. So that's actually really good. So predominantly, well, exclusively, I'm going to talk about safety huddles today. So I'm going to outline to you why we need them, because safety in healthcare actually is a little stuck. I'm going to outline the importance of non-technical skills, which really are encompassed in the safety huddle, and as outlined in the programme, the anticipatory nature of a safety huddle. And asking ourselves the hard question, can we teach people these skills? Sometimes they don't come naturally. We expect them to be there inherently, and they're not. So again, to remind ourselves that safety and physiology actually are right down at the bottom of the Maslow's hierarchy of needs. So this essentially is the deteriorating patient, safety in relation to physiological deterioration. So if we're not getting that right in our hospitals, then we do have some hard questions to ask. So what is patient safety? Well, here's a definition: avoidance, prevention, amelioration. I mean, you can guarantee anything with those types of words in its definition. It's not going to gain immediate attention. And this is part of the problem of safety, is that it's very hard to quantify what you prevent and your added value by prevention. If you Google WHO and patient safety, you'll get a fact sheet, and this is the headline fact, that 1 in 10 patients are harmed in healthcare, and in fact, that in hospitals, I should say, that rises to 4 out of 10 in an outpatient or GP setting. And so that's a pretty startling fact, actually. Is it any different in Ireland? No, it's not. And in fact, if you kind of Google anywhere around the world, you will get these figures. Somewhere between 10 and 15% of patients suffer harm in hospital healthcare. This is a study that you're probably all aware of, the IMA study, repeated over the last number of years, and pretty much consistent. The level of percentage of admissions with harm or one or more adverse events is somewhere between 10 and 15%. This is from the Joint Commission in America. It's a while ago now, but it was basically looking at sentinel events. Sentinel events are serious events. They're either temporary harm, serious temporary harm, or permanent harm, or death. So it's quite the top of the rank of harm. And if you look at the key causal factors there, 3 out of the top 3 are all non-technical. So how much effort do we actually expend on actually training these skills, looking at these skills? And if you look at the bottom there in relation to medication error, we spent a lot of time on medication safety, and quite appropriately. I do not want to take away from that in any respect. But look at the top 3 and how much effort and time do we expend on these? This is from NCPOD data, again from 2009. This is a report called Caring to the End, where they analysed all deaths that occurred in the UK within 4 days of admission, and they looked at the processes of care. So they had a whole team going through notes and looking at the processes of care. And in 13% of cases, lack of communication or poor communication amongst teams was thought to be a significant issue, and it was right across the board. It was within disciplines, between doctors and nurses, between everybody and everybody, essentially, and between senior and junior as well, actually. And, you know, I think we can all relate to that. I see loads of heads nodding, actually, so I think we can. This is from the state claims. It's a bit old now. If anybody else has more recent data from this from state claims, I'd love to see it. Again, communication failure at the top of the list. So, defining realisation of the 1990s was around patient safety. You know, we all sort of kind of got the big media flash around the Institute of Medicine report. But in actual fact, we haven't changed much over the last years. Now, perhaps we have. We've made individual inroads in specific areas. And unfortunately, things have caught up with us as well. Medicine has got more complex. Healthcare organisations have got bigger. So maybe we are, but just the problem is getting bigger as well. But either way, we're still stuck with a lot of work to do. They're the 2 reports I just mentioned. A recent commentary piece there basically said, who killed patient safety? Because even though, you know, we thought we were making inroads, we're not. And in fact, we may even have started to get a bit of kind of numb to this whole thing, where the abnormal has become normal. This is from 2016, where the Institute of Medicine data was revisited, and basically all sources of data were kind of recalibrated again, and it was estimated that actual medical error was the 3rd leading cause of death. And if you look at the others, cancer, heart disease, and COPD, and think about the time and energy, resources that go into those, and when we think about patient safety. So, I mean, I know I can hear a collective gasp when you compare airline safety with healthcare safety, because, oh, they're not the same and all the rest of it. But I'm not asking that question. I'm asking, is the safety culture the same? So what is safety culture? It's this thing that's hard to define. This is the Manchester Patient Safety Framework. You're probably all used to it to some degree. The top 3 are sort of the, you know, the ones where you don't want to be, and the top 2, D and E, are the proactive and generative. problem with the top 3 is they can generate lots of activity, lots of audits, lots of strategies, lots of policies, lots of investigations, which absolutely are all necessary. I'm not taking away from that. But sometimes both the patient and the healthcare worker can get lost in that, and sometimes they don't have the impact they should. The safety huddle works down here, and it works down here because it changes safety culture. Again, if you look at that through the framework of Safety 1 and 2, if you're familiar with that, the safety culture works right across the spectrum of Safety 2 because it sees humans as opportunities as well as risks. I'm buzzing a bit. Can you hear a buzz? And there's a buzz up here. Okay. So what is a safety huddle then? It's a very short gathering, ideally 15 minutes. It's stand-up, it's multidisciplinary, it's at least once a day. And it focuses on safety. And that's important actually. They're not operational huddles, so they're not about patient discharge, unfortunately. You can have those as well. And they're not about other things. It reflects on what went well yesterday, so it's not all negative. It's capturing that learning from excellence concept where, you know, you can reflect as a team, what did we do well yesterday? It also follows up on yesterday's actions in a very specific way, not a nebulous way. And most importantly, it anticipates, mitigates, and prevents harm for today. It's highly structured. That's really important because if you lose your structure, you will lose your safety huddle. So it will revert back to a handover. It will revert back to an operational huddle of some kind. So you must have a structure. That's part of the work that we've done. And it fosters this concept of psychological safety. Now, psychological safety, as you know, is the sort of fashion of today. What is it? This is what it is. So it's not something like just friendly. It actually is, it's a robust interchange between people, and what it does is completely flatten the hierarchy so that everybody feels empowered to speak about concerns they might have. And we know that. We know that the person closest to the patient, it might be the most junior person who has the most knowledge and that inkling concern that something is wrong, and specifically with the deteriorating patient. So the safety huddle works with all of those, and that's why I like that graphic actually, because the two hands protect the healthcare workers as well as the patient. So, you know, you can go onto IHI and get a set of tools how to implement a safety huddle. And I'll just briefly share with you the initial work we did. First of all, we did do that. We went off and all of us got quality improvement training, and we did it as a quality improvement project. Our aim was to reduce poor outcomes by 50%. And you can see there how we define the poor outcomes: cardiac arrest, news not improving greater than 7, and transfer to the ICU greater than 6 hours. In actual fact, we increased the interval between cardiac arrests by more than 6-fold. This was on the surgical ward, and our poor outcomes reduced among patients with news greater than 7 from 25 to 4.7%, and we published this in this patient safety journal. So you can see it there presented graphically. The interval between cardiac arrests significantly increases after we introduce the safety huddle. I have to acknowledge these people, sorry for the grainy photographs. That's Claire Costigan, AMP, Mary Doyle and Katharina Healy are CNM2s, and Caroline Cullinan, who's the surgical registrar. And this work was accepted as a finalist for the healthcare awards. You can see we're all smiling there. That was just pre-COVID. So those smiles will never be the same again, possibly. And again, just to mention that role of the advanced nurse practitioner, I know Derek is going to talk about it later on, but we were fortunate enough to get successful funding and train the first AMP in the deteriorating patient, but we recognised very early that we had to include this quality improvement and safety huddle methodology in what we were doing, because it's much more than like pulling people out of the hole once they've fallen into it. We want to stop people falling in the hole. So we spread it out through various other wards in the hospital, and some of the wards managed to achieve 500 days without cardiac arrest. That's going to Abilene's goal of, you know, no preventable death. It was invaluable in COVID-19 on the COVID ward, and it was invaluable during the cyber attack. We had no other way of communicating in relation. So that sounds easy. Unfortunately, it's not. And as everybody knows, it's really hard to maintain these things. And it's really hard because actually people hadn't had training in the fundamental non-technical skills. Now, these are the fundamental non-technical skills you get, as according to NOTS, which is actually a surgical training program. But if you Google anything in the airline industry, they're the same domains pretty much. And all of these are contained in the safety huddle. So that was the question that we asked ourselves, is can we train people to be proficient in non-technical skills? So we use this methodology called proficiency-based progression, as I had previously published in this in relation to non-technical skills. And it is proven to be more effective than standard simulation by orders of magnitude, in fact. So what is it? And if you just bear with me for a while I explain it. What it is basically a methodology where you look at what you're doing as a procedure. Predominantly this has been used in technical skills, but you basically analyze and task analyze that procedure completely, usually through video analysis. And you come up with a series of metrics. So there are a series of definable behaviors that make an optimum performance of this procedure. They have to be reliable, so people have to be able to score them. So they're not judgment-based, so two people can get exactly the same measurement if you were to observe them. They're valid, and you do that by presenting them to a Delphi of expert people. And then you use those metrics to build the simulation. So rather than building the simulation backwards, you build it forwards. So now you completely understand the work as done. So you're building the simulation from the work as done. And then you define a proficiency benchmark. How do you get that? You run experienced personnel through the simulation and you get their mean performance. So you're only expecting people to perform as well as experienced personnel. And then through all stages of this, anyone who's doing training must reach the proficiency benchmark. So it's not based on any judgments or subjective assessments, like, for example, meets expectations, whose expectations, and what are those expectations? They're very definable units of behavior. This is an excerpt from the paper I'm going to show you in a minute, which is this one. I'm not going to go into this in too much detail, but it is very relevant to the deteriorating patient. So basically, I did this study with UCC. We randomized 90 medical students and nursing students in pairs to 3 different groups. One group did online training, one group did standard simulation, and one group did proficiency-based training. And then at the end of it, they all did a high-fidelity simulation assessment of a standardized case, which was videotaped and then scored according to the metrics independently by 2 blinded observers. So you can see here the PBP group completed significantly more steps, had significantly less errors, and most strikingly, more of them reached proficiency than either the online group or the standard simulation group. Now, I should say the proficiency group and the standard simulation group had exactly the same materials, same cases, they had to make simulated phone calls to each other, same everything, same number of facilitators. But just in the proficiency group, the pairs had metrics and they fed them back to each other and they had to reach the proficiency benchmark. Their partners had to tell them that they reached it or not, and then once with a facilitator. So building on that work then, I suppose we wanted to extend that to what we had observed with their implementation of the safety huddle, and we were fortunate enough to get a HRB grant to do this. It's a before and after design, and basically we're going further now. We're not just looking at practitioner levels of performance, we're actually going to look at patient adverse outcomes. I'm getting the 5-minute warning. It's pretty stressful, that 5-minute warning, I have to say. Anyway, that's the study design. But just to tell you that we're actually on the tail end of it now. So we're doing before and after adverse event measuring using the IHI trigger tool. We've developed the simulation program. We've done the metrics. We've validated them thanks to people from the DPIP program here who participated in the Delphi. And we've implemented that in real life. Now, the simulation program is a ward-based simulation program. It's not done in a simulation lab. It was done in the height of COVID Omicron wave, when the absence rates were just through the roof. It was an enormous challenge, but we did it. And we also built an online program that you had to do before. So you do an individual online program, and then you do a team simulation program. And the team has to pass the benchmark, not the individual. Thanks to all these people. Some of them are sitting in the audience here, so thank you very much. And just to acknowledge our PPI who's been involved since proposal stage. That's the IHI trigger tool. That's what we're using to capture adverse events. These are the various phases. I'm not going to go through them, but the metrics consist of a series of steps, errors, and critical errors. I can tell you there's more than 100 steps and there's more than 100 errors. And we got everybody through which is at a 90% or above proficiency benchmark on both the online training, which is this, and the simulation program, which is this. So we actually have to build all this simulation. We didn't have a fancy electronic digital news, but it can easily be transferred to that. Obviously, COVID-19 presented a huge challenge to us, but it was actually also an opportunity because we are concurrently measuring adverse events through successive COVID waves. So we're actually going to look at that now as well. So throughout the course of the study, we've developed validated metrics for optimum safety huddle performance. We've defined a proficiency benchmark. We've built an online training program and an in-situ simulation program. We feed the metrics back every week for 6 months after the intervention, and we're also going to do videotape analysis of safety huddle performance, so we've only got one more videotape to do. And it's just to say that it's more than a simulation training program, it's a behavioural team intervention to change safety culture and improve outcomes. We're on social media. You can look at a show reel there of our online course and follow us on Twitter and all the rest of it. So basically, just to summarise then, safety in healthcare does seem a little stuck, possibly because I don't think we've actually really attacked some of the really key underlying factors, which are these elements of non-technical skills, which don't come naturally to us, and through which we've inherited years of hierarchical structures in our institutions. The safety huddle is this powerful safety culture tool, but it does require key non-technical skills. And you can train people to have these skills as teams rather than individuals. So if we want high reliability organizations, we really need high reliability teams. And if we want that, we need to train people on all these skills. Look at these skills, the 5 core elements of high reliability organizations and teams. These are all encompassed by the safety huddle. Thank you.
Thank you very much, Dorothy, for that. Moving on to our next speaker, who is going to be accompanied by some team members. So our next speaker is Sue Markey. And can I just do a check that down the back can hear okay? Yeah, thumbs up, okay. Sue is the Deteriorating Patient Lead for the RCSI group since the end of August 2021. She worked for the previous 8 years in nursing practice development in St Vincent's University Hospital as the facilitator for iNews, iMuse and sepsis, and has been a passionate advocate for the deteriorating patient. Sue is going to be joined, I'm not sure if they're coming on stage with you, but they're here in the front. You're coming up with her, right? So Sue is going to be joined by 4 colleagues. Liz Casey, Liz is the last one approaching the stage, so in reverse order. So this is Liz next to me here, and Liz is Resuscitation and Early Warning Scores Training Officer, Nurse Sepsis Lead in Mayo University Hospital in Castlebar. Yvonne Young, Yvonne is in the red suit at the end. So Yvonne is currently the aid-on for sepsis in the University of Limerick Hospital Group, but she's actually on her way, hopefully, to become the national lead supporting Evelyn in the DPIP programme. Christine Sheehan, who's beside Yvonne, just next to her there. Christine is an advanced nurse practitioner for critical care and outreach in University Hospital Galway, part of the Sailtor Group. And I've known Christine actually for years back in the day as well when I worked in the Galway Hospital, and Christine has certainly been an advocate for critical care and advanced practice way before anybody in the system, so she's definitely a pioneer. And next to Christine then is Mary Bedding. So Mary has just, have you taken the step into the half? Yeah. So Mary has just moved from being the hospital group RCSI aid-on for sepsis into the DPIP programme as well as a lead supporting, project lead supporting Evelyn as well. So a huge congratulations and welcome to them all to the DPIP programme. An excellent calibre of people. So I will hand it over to yourself then.
Thanks, Ger. and thank you, Aveline, for inviting us here today to talk about the learning in action. And I suppose, again, Aveline has referred to the fact that we've gone from a national early warning score to an Irish national early warning system. So in 2013, I suppose the score started. The National Early Warning Score was version 1 of the National Clinical Guideline, and we're now using version 2, which is the INEWS, or the Irish National Early Warning System. So I suppose looking at it was implemented in 2020 and relaunched as version 2. And that resulted, I suppose, in the evolution of early warning systems internationally, and it happened at the same time here in Ireland. And these systems, I suppose, reflect all the elements of the management of the acutely unwell patient. And that's the system of anticipation of deterioration, through our cues for caution, our gut instinct, our clinical judgment, and our situation awareness for everybody through safety huddles. There's also the next phase then of the system is the actual recognition of the deterioration. So if you're a junior member of staff, you might be relying on the INEWS observation chart to inform you as to the recognizing it. But if you're an experienced nurse in the system or a manager, that you know from your clinical judgment and your gut instinct often that the patient is deteriorating. So you're recognizing it, then you're escalating it, and you're following the system of the escalation and response protocol that there is. So whether you're using INEWS or IMUS for maternity, or pediatric PEWS for pediatric patients, or the emergency medicine EMUS, they're all systems, and the systems of anticipation, recognition, escalation. The response then, the response piece is also very important. And again, we have the 3-tiered response, which is the bedside response, the actual urgent response, and the emergency response. And some of the girls will talk a little bit more about the detail of those. And then obviously we have the governance piece. So the governance can be broken down into the clinical governance and the governance at the bedside, which is the evaluation. So looking at the assessment of the patient and the interventions, and then the reassessment of the patient and how the interventions have actually gone and what's the outcome for the patient. Then there's also the organisational governance, which is looking at the deteriorating patient committees, your audits, your after-action reviews, your improvement cycles, and things like that. So what we're going to do today, we're presenting that learning in action. So Liz is going to talk about the situation awareness piece, and that's the safety huddles in Mayo General. And Mary is going to talk about the recognition and the changes to the INEWS version 2, and then she'll talk about the recognition of sepsis also. Christine will talk about the response and the critical care outreach service that's very well established in University Hospital Galway with the advanced nurse practitioners. And Yvonne will talk about the governance and the organisational governance that they have in Limerick. So we might start then with Liz. Liz, you might just tell us about your experience and your identification for safety huddles in Mayo General, and then your experience of setting them up.
Hi, can you hear me? I'm naturally loud anyway, so I possibly don't need the microphone. Yes, so we wanted to be able to, in Mayo University Hospital, we discussed setting up our safety huddles, and we had safety huddles already set up, but we wanted to streamline them, put more structure on them. So forgive me now if I keep an eye on my cheat sheet here. So we wanted to anticipate the deteriorating patient earlier when the use is triggering and in the lower numbers, as these are the patients that are most vulnerable. We also wanted our safety huddles to be proactive rather than reactive, and we wanted to further improve our compliance in the escalation and response piece. So how did we do it? So with the DPIP team, in collaboration with DPIP and the Royal College of Physicians Ireland, with the SAFE programme, we aimed to streamline our ward-based safety huddles, and we chose our pilot ward, which was an acute medical ward that also incorporates the stroke unit. We devised that the early warning system would be added to the safety board. You're all aware of the safety boards everybody put their hands up to say they had safety huddles. So you know the safety board that I'm speaking about where we do the patient handover? So we added a use column to that very simply. So every patient in our safety pause during that handover piece, the use would be discussed regardless of the score. So there had to be something written there, be it 0, be it 1, be it 3, be it 7, as long as there was a score. So we knew then that that piece wasn't missed. So that was the first part of it. And the second part then, through the RCPI and through the SAFE program, was to design a script. And it was the script that gave us the structure so that nothing got missed. Obviously, if I'm the clinical nurse manager and I am doing the safety board and I'm more in control of the board, I know what's happening, I've got greater situation awareness. But what if I'm a new member of staff? I may miss something, I mightn't have that structure straight away, that piece, so that actually streamlined that for us and helped. So what's in our script? One of the things we ask, if the use is elevated, the questions that are asked then are, sorry now, I've lost my piece. Has the frequency of observations been increased? Has it been escalated to the appropriate person using the ISPAR communication tool? Have you received an appropriate response? And do we have a clear management plan? Most importantly, how is the patient at this time? Also, which consultant team is going to address this? Because you could have different teams that are on, it could be out of hours. And also, the final part was, who is actually going to take responsibility for this before we leave the safety huddle? So to make sure that we have that closed loop. The other part of the script that we used was, excuse me now, the cues for caution. So we do know that where the use was triggering and it was being discussed, but what about the patient who actually wasn't triggering? That was another piece that we wanted to be sure of, especially if I was a newly qualified member of staff or a new member of staff in that clinical area. So how are we going to manage that? So again, the cues for caution is part of the script, and we do discuss it. We go through the script on each of the safety pauses, and the question we'll ask is, any patients on increased oxygen requirements, for example, any patient undergoing special therapy, any patient on new medication, has the patient moved from a higher level of care? Maybe a patient has been moved out of the stroke unit onto the ward, or a patient has come from HDU or ICU to the ward. What about nurse or gut intuition? Another key piece. And it's lovely now as our safety pauses are more established and they're happening. They were happening anyway, but now that we have the structure, it was quite nice the other day, or reassuring to hear somebody say, the use is 0, but I'm not happy with that patient. You know, that piece that was potentially missing previously. So the staff themselves, when we talk to them about the safety huddles and the structured template that we're using through the script, they themselves are saying they feel more empowered and they feel more supported, especially junior members of staff where maybe the clinical nurse manager isn't on that day. Again, that person who's very, very specialised in what they do, but somebody else is coordinating the shift. So it gives them, they feel more supported, more empowered, and they say the communication for themselves across the multidisciplinary team has improved as well from that perspective.
Just to ask that question, do you have multidisciplinary input in your safety huddles?
We don't have multidisciplinary input at the moment in our ward-based safety huddles, no, but it is something that we have talked about and are discussing, but we don't have it at the moment, no.
Okay, that's great. Thanks a million. That's great. Thanks a million, Liz. So Mary now is going to talk about remind us about the iNews changes and their impact, I suppose, in the clinical environment.
Can everyone hear me? Yeah. I suppose we all know about recognition, it's so important to recognise early that people are deteriorating, because acute physiological deterioration is a medical emergency which needs to be recognised and treated. So I suppose, and we do know for patients that are deteriorating that 12 to 24 hours before a cardiac arrest, there are certain physiological changes that we can see by doing the vital signs. So as we look at those and we can track and trigger that and trend those in the iNews document that we have, and it's very good at picking up the patients that are deteriorating now. We know that the new chart is very similar to the old one if you've used it. All of our parameters, there are 7 parameters: the respiratory rate, the saturations, the systolic blood pressure, the heart rate, the level of consciousness, the temperature, and whether a patient is on supplemental oxygen or not. Each one of those is scored according to the risk. So 0 is the least risk, 3 is the highest risk, and then you total those scores together. And that will give you a response to that, how often you should, how frequently you should do, the minimum frequency of the observations, who should review that patient, and what response should be to that review. We do know that in using the paper-based system, that it is prone to errors and sometimes omissions. So obviously the digital iNews will help with that, and I'm not going to go over that too much because Natasha and Jerry are going to talk about that after the tea, but we would hope that that would make the whole system more accurate and lead to a more timely response as well for escalation. There are a couple of new things in the iNews National Clinical Guideline when it comes to the form. The first one is healthcare worker, patient or family concern, and it's at the very top of the form for those of you that are used to using the new form. And it is extremely important. I suppose this is where clinical judgment comes in. It's where your gut instinct might kick in, or your own experience. So it doesn't score anything, but if you do have, if that concern is there, at the very minimum, a set of observations and an assessment must be undertaken. And when that's undertaken, regardless of what the score is, if you feel that they need to be escalated, then they are escalated. So that's the first thing. The respiratory rate is at the top of the form still. It's the most important vital sign when it comes to deterioration. So that's why it's at the top. If you've ever wondered why, that's why it's up there. And early recognition of increases in respiratory rate are so important. The second thing that has changed would be the, down under the disability section, the AVPU section, there's a new onset confusion or change in the mental state, which would respond, which scores and automatically scores a 3. And I know from the work that we've done in sepsis, we would often see that, particularly for elderly patients, the first thing that you might see is that somebody is confused. And in the old system, we would see people that were very, very confused, but they were actually able to talk to staff. They were able to respond to them, albeit that they might be talking a load of rubbish. And people would say that they were alert, and they didn't score anything. So thankfully, with the new key acute, I suppose, altered mental state or new confusion or delirium will score a 3 automatically. So you only have one other parameter, let's say in sepsis, that has to be abnormal to score you a 4 or more, where you should screen for sepsis. So we find that particularly useful for deteriorating patients, and particularly in sepsis in elderly patients. The other change then, I'm trying to think now, my cheat sheet here. Yeah, they would be the 3 really. And then of course there is the responses that Sue alluded to, the bedside response, when the nurse in charge would review the patient and may decide on whether there should be some sort of escalation or not in response to the review. And that's for low scores. Scores of 3 to 6 then, there's a more escalated response depending on what the number is, and more frequency of the OBS, and more senior people to be involved in that response. And then for scores of 7 or more, which we, when patients have a score of 7, we know that these patients are very unwell, and we normally find that they're escalated very quickly. People do respond to that deterioration. But I suppose what we do have a little bit of concern about is the patients that are 3 to 6. And sometimes we find that they're not escalated as appropriately as they should be. Maybe their OBS aren't done as frequently as they should be either, and that's really important that they're picked up as well. And then I suppose, as I said, for sepsis, was my background prior to this, has been sepsis. The other thing is with the immunocompromised, that gut instinct or clinical judgment kicks in, and for immunocompromised patients, often they don't have the signs and symptoms that we would expect in deterioration. A lot of them might just say that they feel unwell, and they may have an infection or whatever. But a healthcare worker who has looked after those types of patients will know from their own experience how quickly they can deteriorate. And so they, regardless of what the score is, they need to use their clinical judgment, act on their gut instinct, and they need to escalate those patients.
That's great. Thanks a million, Mary. And I suppose talking about the 3 to 6s, we do know that they are the ones that people don't escalate as frequently. So we have to be aware of that cycle of clinical futility that does exist, and we know it exists in all clinical settings. So just to be aware of that, and probably especially with junior staff who have that fear of escalating all the time if somebody keeps triggering, and it's really making sure that they understand the importance of that, and that maybe they're not necessarily competent enough to know and to understand the importance and the consequence of that on the patient outcomes. So thank you very much, Mary. So Christine now is going to talk to us about the response element of the system, and she's going to talk about the role of the critical care outreach and advanced nurse practitioners in Galway.
Okay, thank you. I suppose just like Mary was saying, the response bit is where things can fall down a little bit, and it's due to multiple factors. And we could see this as a whole where an advanced practice role would come in and could fit into that niche to assist that, particularly with your 3 to 6s. And again, the availability of people to respond. It could be, and it's not out of the fact that they don't want to respond or they don't want to pay attention. The hospitals are busy, aren't they? And you'll have people, you might score and need a medical reg. That medical reg could be with another patient already. It could be the night and it's the surgical reg and they're actually in theater. So there's a lot of areas where you can't get the response you're expecting. And really what we want to see is you get the same response regardless 24/7, and that would be our goal for the future. So we could see a role for the A&P in critical care here. I was very lucky to have a very supportive group of administration and consultants that were willing to start supporting this back in about 2014, which when I think it's that long, I actually can't believe it. So I was successful in interviewing for the post of developing the A&P post in Galway. The one thing about this is and a lot of people are at this point now where there's 1 or 2 of you, okay? And 1 or 2 of you can't run a service. But you are a very important beginning of a service. Okay? You need to do the groundwork. There's things like when you're going out to the wards, how the nurses perceive you, because initially you're going to get, why are you here? What? Once they get to know your service, then that changes dramatically. So at the moment now in Galway, we're up to, I'm going to get the numbers wrong and I shouldn't. We will be up to hopefully 8 A&Ps by next year. We're currently at 5 when we have 1 candidate, okay? And we're running a 7-day-a-week service with 24 hours on the weekends. Because another problem with the response model, as I said, it needs to be the same 24/7. So our goal in the future would be that we are a 24/7 service so that you are getting that same response. And that's why it was important to us as a team, too, that we're at least part of the escalation plan now. And where do we sit with that? There's a lot of different things. It's a great opportunity for nurses to develop. And you want to keep nurses clinical. We see a lot of nurses leaving clinical areas because they don't know where else to go. So it's a great place to stay clinical and keep those clinical skills and foster clinical skills in other nurses on the wards. Important thing is we don't take over care. It's not about we rush in as the superhero and take over the care of the patient and hear everything. We support the care that's being given to them by the nurses and escalate where necessary. And this has been one of the biggest advantages, I think. Nurses are happy to see you coming because they think they have somebody to help them manage this. We can be a very good go-between between teams and the nursing staff also. Lots of things have changed, and we're still developing the practice. For instance, and this is why it's really important for all nurses to look at the differences in their hospitals. You can, when you're out on the wards, you begin to see areas that need advanced. For instance, PICC lines. I don't know how long patients have to wait for PICC lines in your hospitals. So we now are, 2 of the nurses for the outreach team have started a PICC line service, which will hopefully grow too. So patients wait 24 hours rather than waiting 2 weeks to get an IR PICC line. So there's lots of places that you can look at expanding the practice of these roles.
That's great. Thanks a million, Christine.
I'm done. See, I told you I could have talked a lot of time.
Thanks a million. We've got the 5 minute. Okay. Yvonne now is going to talk. Yvonne, you might just talk about the clinical's governance structure that you have in UHL and how it's developed over the years.
So I suppose, like lots of us here in the room, I was redeployed for most of the pandemic and doing lots of different roles. So one of my first things I was asked to do when I was released back was actually to implement the INUs across the UL hospital group. So I was very fortunate that I was actually involved with the guideline development group with Evelyn and Serena and Miriam, and that really gave me a good background and kind of exposure and I suppose access to people. And just before that, before COVID, we had many different kind of committees in our hospital group, like an early warning score committee, a resus committee, a sepsis committee. And, you know, if I'm honest, you know, especially with the early warning score, we felt so frustrated because it really ended up just being a couple of nurses coming to a meeting with no real decision-making power. So because I was involved with the clinical, the guideline development group with Evelyn, I actually had exposure to lots of talk and lots of hospitals setting up these deteriorating patient groups. So I actually, with a colleague, we actually wrote a proposal to the executive management team, actually in the ISBAR format, saying, you know, we feel that some of our committees are ineffective, we don't have decision-making power, you know, we propose a group deteriorating patient committee. And it was really important that we ensured we had a good, strong chair with real decision-making power, and actually we proposed that the chief clinical director chaired it. And actually he did. So because he got it, he believed in it, you know, so that was amazing to have him on board, because with governance, you know, it's so important to ensure, you know, accountability, you know, reliability, transparency, decision-making, and of course, resource allocation and funding. But you must get that governance piece from the board to the floor. So now we had the board. We had the executive team, and actually a lot of the members were made up of clinical directors and also people like from the resus department. We had our critical care advanced nurse practitioner. We had, you know, me from, I was representing sepsis. You know, with all the different, you know, specialties around the table who had decision-making power. So we were really doing really well and doing lots of good work. It was very much in its infancy, and then COVID hit. And it was like, so as you all know, to explain what happened, lots of things didn't happen. So one of the first things I had to do before I implemented the INUs was get the governance piece in place again. So we just had to restart what we had done before the pandemic. And that was really difficult because people were fatigued, people had changed roles, we weren't all allowed in a room. We had to do telecon. It's not the same as being in a room. It was really challenging. And also to have, you know, with a change in chief clinical director, we still had to ensure we had a very strong chair, a clinical person, a senior person as well. But once we had that in place, you know, they got it. We had the backing of the INUs, and then we had to go to the floor. And so one of the first things I did was actually invite Evelyn and Serena down, and they spoke to the Deterioration Patient Committee first of all, and then they met the frontline people and the CNMs, and they went up and visited wards, and there was a great buzz about the place. And the reaction from that was actually it drew a lot of natural champions, and without those champions I couldn't have done what was done, implementing it across the whole group. And some of them are sitting here in the room, and thank you so much, and some are tuned in online. They're just phenomenal people, and so that was really helpful. And also we took a systems approach, a group approach, because our hospitals interconnect. You know, they all communicate with each other, and lots of our patients step down or move around within the group, so we had to do it from a hospital approach. So it was really good. Now, out of that as well, we also had to develop many subgroups, because it was just a big, big project. You know, we had to do a communication subgroup, an implementation subgroup, an education and training subgroup as well. And also I find that this Deterioration Patient Committee, it was a really good forum for escalating concerns. And I'll just give you one quick example. In the Model 4 site, we're getting lots and lots of, you know, maternity and postpartum patients who need to be monitored on IMUs. And we realised, you know, God, majority of our staff are not midwives. And, you know, this cues for caution, you know, the patients who are being looked after outside of their specialty, they should be treated as high risk. So we brought this to the table. And out of that then came audit, and out of the audit we were able to report back on, you know, there's variability, there's concerns, we're seeing things, we need education, we need training, and then out of that then came a QIP. So we did face-to-face education, we developed resource packs to reduce variability and create standardisation. We also promoted the e-learning programme, and we also put up an iMuse awareness clock beside our iNews clock in the Model 4 site. So people walking up a big long corridor, they can't pass it without reading something about iNews or iMuse, or, you know, and we also had to develop things like, you know, big communication plan and awareness, and just, you know, make sure it gets out there to everybody. You know, that's really important, that we're getting that message out, and the same message out to everybody, from the board to the floor.
And just one more question, Yvonne, just for people who might not have set up a deteriorating patient committee. Did you keep all your other committees, or did you merge them all into one?
So we actually subsumed a lot of them because, to be honest, Sue, they had become ineffective. So we are at the stage now where we're bedding in the Deteriorating Patient Committee, and we're actually, our next meeting is next week, and we're actually going to look at the terms of reference again, because we actually may have to set up some of the subgroups again. And, you know, but it's really helpful having a lot of those people around the table. Like, for example, we have members from the resus department, and they actually feed in lots of really fabulous data about, you know, the cardiac arrests and respiratory arrests, and, you know, things like, you know, the iNews score at the time of arrest. And so those are really helpful to actually influence our education and training and what's needed, and the resource allocation as well. But we may have to look at that again, you know, but it's, at least we have that forum that we can escalate up to look for resources or, you know, funding and things like that.
Thank you very much, everybody, and hopefully that will either reaffirm what you're doing yourselves in the hospital, or that it might help you maybe advance the cause of deteriorating patients in terms of governance or critical care outreach in terms of response and safety huddles. Okay, thanks a million.
Thank you very much. And so according to the clock at the back of the room, it's approaching 11:30, and according to my schedule at 11:20, we're meant to be going to coffee. So I'm going to make an executive decision around the Q&A, and I'm going to ask the audience, if anybody has any burning questions, raise your hands, and we'll take about 2 to 3. So please feel free to do so. So if there's something you'd like to ask, raise your hand, and we'll get a mic to you. One at the back, this side here, yeah.
Sorry, I'm an EWS coordinator in a smaller hospital, and I suppose we don't have the structures that might be in place in the bigger hospitals. So the difficulty that I would have would be engagement with medics. So we get the recognition and the escalation, but then there's not the engagement that you would want from either the junior or the senior staff and the consultants, and that's really difficult for nursing staff. You escalate, they don't want to change, they don't want to make a medical decision about the EWS, they don't mention EWS, and that sort of is quite a difficult. I don't know if there's anyone who can sort of
give you some guidance on that. Christine? Yeah.
So have you implemented the new iMuse yet? Okay. So are they willing to look at doing monitoring plans? Because one of the big changes is there's no more adjustment of the early warning score. So I don't know if people are used to seeing that adjustment of a score for oxygen or whatever.
Sorry to interrupt. We had actually, about a year and a half before the iMuse, we had actually made an EWS. We noticed on audit that there was no mention of EWS in the medical notes. So we brought in a very similar iMuse management plan, but it was implemented, but it was implemented in NACE, and no, there's no engagement with that, unfortunately.
Yeah, I think, and I might ask you to, if you have any comments on that, the committee lead has to come from the top of the hospital, and that's the only answer, to be honest. I had similar problems where I took over the sepsis committee for a while, and I realized that that was useless because I don't have the pull power, basically.
Yeah, I totally agree, and that was one of the things we had to do, be very strategic. It was get those senior people at the table as chairs and as leads, because that's what will bring bums to the chairs. And also, when I was implementing, I looked to go into every department, and if I got a no or a no answer, or if there was silence, you know, I would actually get on to the Chief Clinical Director saying, can you get me into the Department of Medicine or the Department of Surgery? And actually, once you get your foot in the door, there was engagement. You'll always get one or two, you'll always get barriers, but the vast majority were engaged.
Okay, thank you very much for that. Any other questions? Raise a hand. I'll be proceeding if I don't see any hands. I know you're all gasping for coffee, and well-deserved, might I say. So I just have a couple of more things to say to you. So one is, at the top of your agenda, there is the Wi-Fi code and password, just to say that. Secondly, at the top of your agenda, there's a QR code for your evaluation survey. Do fill that in online. Thirdly, you're to be back at 11:50, come hell or high water. And before I thank the speakers, I'd just like to acknowledge in the room today Derek Cribben, who's the nurse lead for the critical care programme, and Una Quill, who's the programme manager, and a lot of the developments in critical care that have been driven and where we're at today is in no small thanks to those and the drive of the critical care programme. I'd also like to acknowledge Maureen Flynn, who's also part of the NQPSD, our office, and QPS, who's at the back of the room, and you'll know Maureen from taking her lead on quality and patient safety, and she publishes for the WIN article magazine on a regular basis. So just those people are here as well, and it's useful to network and talk to all of those. As I said, the speakers are all around, so feel free to network. And finally, on behalf of Aveline and Blaunet and the DPIP project leads and the programme, I would like to express sincere thanks to Orla Healy, Dorothy Breen, Sue Markey, Liz Casey, Christine Sheehan, Yvonne Young and Mary Bedding for giving of their time and expertise this morning. And lastly, but not leastly, to Evelyn Casey, who has led out on this, and really congratulations to Evelyn and the programme. And so enjoy your coffee, everyone. Thank you.
Should I open that?
You don't need to. No, you don't need to do anything because you've no slides. We just have a stand with slides while you're in it, so they don't need to because they're just going it from there.
Fine.
So that doesn't even need to be open, and all the sound and everything is controlled from the guys at the back. So it's grand.
Will I be okay? Like, huh? Will I be okay?
I don't know. Will you?
You hold my hand, like.
I can if you want. I can see you. Look at you.
Okay, good afternoon, everybody. I think we're just about moved into the afternoon, or good morning. It's a great privilege to be here. Mike O'Connor is my name. I'm a National Clinical Advisor for acute hospitals, and I suppose acute hospitals are many, and I suppose there are 1,200 beds in acute hospitals, and there are really fantastic things that happen in acute hospitals on a day-to-day basis. And then there's some nasty things that happen, and really, I think this conference is all about actually improving the care and the quality of care and the early recognition of patients as they transit to our hospital. I feel a little bit uncomfortable because I'm in the Royal College of Surgeons for the very first time, and as a physician, I feel I'd be chucked out the back door. But if there are any surgeons, it's important. In the history of medicine, physicians used to hire surgeons to do their amputations and the like, actually, to be honest. I can see the surgeons by them not smiling in the audience. So it's a great privilege to be here, and just for a little bit of information, there's a slight change to the running order. For today, obviously, we have the Cavan experience, which I'll introduce in a second. We have Gregor McNeil, who's kindly come over from Edinburgh, and Patricia Hughes is on instead of the one that was on the schedule, really. So it's just a slight change, really, effectively. It really is a fantastic experience to be here. It's a privilege to be involved in people who are involved in the deteriorating patients. I see Evelyn down in the front row, who's still kicking people to encourage them, injuring herself with her boot at the moment. But there's a lot of people really have devoted a lot to bring the project over the last number of years, the early warning scores to the new modified early warning scores to vital signs automation. And I think the vital signs automation, I think we're going to hear a bit about the Cavan being an absolute forerunner in this, really, and we're all very proud of the Cavan experience, which we're going to hear about. The plan is to roll out the vital signs automation in the first phase to possibly about 500 beds. The issue that that's going to cause, though, is that 11,500 other beds are going to say we want it too. And we absolutely, as a community, must make sure that we deliver that for patients. And that's going to take a while, really. That's going to take a while. I see Ronnie down there, Ronnie McDermott, who really has given absolutely fantastic support for that project. There's a lot of people have been involved in it. I went to Kilkenny with Evelyn and Ronnie, actually, about maybe 3 weeks ago, I'd say. And again, just seeing their new unit and this high-end technology promoting patient safety was absolutely fantastic. So I'll stop talking now. That's me done. So we'll move to our first speakers now. We have two. We have Jerry Dignan, who is an engineer in Cavan, clinical engineer, and Natasha Riley, who is a nurse on one of the wards, Medical 2, I think it is, Natasha, isn't it, who sort of piloted the ward. And we're going to hear a little bit about the real lived experience from Cavan, from a change management project to actually doing something that really makes a significant difference for patients. So I think Jerry's going to talk first and then Natasha, so we're delighted to welcome you here today.
Hello everyone, and thanks for having us here today. Like the introduction, my name's Jerry Dignan. I'm Head of Department in Clinical Engineering in Cavan Monaghan Hospital, and together with Natasha we'll share our experience of implementing a digital eye news in Cavan. So Cavan, we're initially ran it out on a single acute medical ward, which was Medical 2. Since then, we've got it into 6 acute wards, so 5 additional wards, and also into our maternity services. So we have the Muse up and running as well. Important in areas like our surgical ward, where you have obs gynae patients as well, who are on the Muse chart, not just the iNews V2. So the initial rollout, sorry, let's start with the background. Between 2013 and 15, the HSE implemented the National Early Warning Score Plan. It was a massive step forward in improving patient outcomes and patient safety. However, it came with all the inherent risks of a paper-based system. Here you can see an example of an early warning score chart, how it would have been filled in the ward, and like, the legibility would have been a massive issue. But as was alluded to by previous speakers, getting the information from them. The chart was in the patient notes. For you to sit at a central location, have an overview of a ward or an overview of the patients in a hospital was very, very difficult. Auditing as well would have been, information isn't readily available. So we have the DPIP's driver diagram here, and on it they had identified a desire to move to a digital iNews system. All the background issues, we're all familiar with them. There's international studies done, there have been national studies done showing the error rates that we've had. Previous people have described their experience with it as well. So although it was a massive step forward, the early warning score system, we had to get to improve it further, unlock its potential. So, So we had an opportunity in Cavan. Our OBS monitors were all coming end of life. So we were approached by the National Medical Device Office to see if we would look at running with an integrated system, an integrated WOW, where we would have a patient monitor connected to a PC, a medical grade PC, which would automatically acquire the data from the OBS monitor. And provide an interface for staff nurses then to also complete the early warning score. So we grabbed the opportunity with both hands. We had a very proactive CNM at the time on Medical 2, Louise Henry. She was a visionary at the time. She really embraced the technology and fought hard that she would be the ward that would have it to pilot. So we took the opportunity and we ran with it. So the pilot project ran on our Medical 2 ward, which was a 31-bed unit. We have 6 bays, one 4-bay and 4 single rooms on the ward. So what we had was one WOW on obviously a workstation on wheels in each bay. So each 6 patients had a WOW. The 4-bay also had one. But in the isolation ward and in the 3 single rooms, we had wall-mounted systems. We use a PDSA methodology to implement the system onto Medical 2. So the first thing was the plan. We set up our steering group, our implementation committees. We had organically chosen our champions. They were nurses on the ward who would actually come to us, looking to be part of it, looking to lead out on it. The plan then, I'll just go on. I'll skip that one for a minute. It was then the do. So on the first week, we went up to the ward and we implemented the training programme. We'd intended then to run the 2 systems parallel for another week after that. So week 2 was the implementation with the paper-based and the electronic system running parallel. And then we were to give 2 weeks support after that. The 2 systems never ran parallel. At the end of the first week, all of the staff were ready to fully implement it. They absolutely took to it like ducks to water. Loved it straight away. It was really positive, but very rewarding for us who worked on the project as well. I'll just go back to here for a second. The benefits which we realised as soon as we went in. We were hit by COVID when we intended launching this first onto Medical 2, and we didn't get in on time. But we took an opportunity between the first lockdown and the second lockdown to do the training. And we were just by the skin of our teeth live when the second lockdown came. Every ward in the hospital wanted it straight away. There was, if you remember, well, of course you remember, will we ever forget? Nurses were doing OBS in the wards. They were getting slips of paper, writing down the OBS, sticking them on the glass panels and doors, doffing their PPE, coming out, and then retrospectively filling it in the chart. None of that in Medical 2 or in our respiratory ward and pre-discharge unit. Straight away, the OBS monitor was in there, it was live, it was done. The central station then, outside at the nurses' station, was there before physicians had to go in to review patients or staff went in to give them care, be it HCAs or nursing. They could review that patient, they could see the trends, they could see everything from the nurses' station. The other thing that staff on our COVID ward used were the notes features. So all their nursing notes were kept in it as well. So they could actually discuss the patients with their notes at hand at the central station. So they're the big benefits at the time. And also probably what developed the appetite in the rest of the hospital. Everybody else was looking through the glass doors from the other wards saying, us next. Then we had the staff engagement. So I'm not just kind of going in order here, but we did listen. When we went to Medical 2 first, we got a lot of feedback, and it was, I want to say it's very positive, it was, but it was critical feedback. It gave us an awful lot to work with. Very little of it was to do with the system. The Synchrify QS300 was working really, really well. We did tailor additional information like pain scores and other aspects that they were using, the blood sugars for diabetic patients and that. So that was all configured. Synchrify were really, really helpful and designed a system for the ward. So, but what did evolve a lot was the WOW, the cart. We started off with an OBS monitor with a tablet on top, We are on our probably 5th generation of it now, which is the WOW that we have at the moment, and it's really well received in the wards. People are really happy with it. MDI did a lot of work on developing and designing that for us. There was a lot of custom features on it. So we're really, really happy with it. The constant staff engagement, we're all the time engaged with them. Practice development, especially from a clinical perspective, they were really on the ward, on the floor, working with ourselves and the staff on the floor to iron out any creases that there were to be ironed out. Most of them were on workflows. Like I said, the system itself was really robust from the day it was put in. Study, got there quickly. We were very fortunate in that we were able to engage with Hi to study what we had done. So the way Hi, they took just shy of 500 charts, 496, sorry, not charts, patient observations, and they did a study on them. They were done retrospectively for the pre-implementation, and then post-implementation, they came back and done another study for us. So in that study, we had 3 types of errors. That's what they were measuring. We're measuring the error rates on the charts. So we had type 1 errors, which had little or no impact on clinical intervention. Typical examples would have been missing patient demographics. So there was a number of those. Type 2 errors were errors which had the potential to affect a patient's care pathway or the clinical outcome. And type 3 errors were observations that weren't completed. So this is our study data. I'll let you just mull over that for a second. You can see the overall error rate, including the patient, but the take-home one is here, which is error rates from the recordings on the new scores. Ones that would affect the clinical pathway of patients, with 59% error rates on our paper-based system. So these were errors that would have had an impact, or could potentially have had an impact on patient treatment pathways and patient outcomes. So when we introduced a digital system, that was reduced immediately to 13.5%. It was absolutely overnight. There was no other reason for that to be reduced. It was 100% responsible for it. Of those 13.5% error rates, every one of them was a late observation. That's the only error that was recorded on the digital system. So then again, that's information for us as well. Why are they late? Is it staffing levels? Is it resources do we need? Is it physical devices we need, if they're enough? But again, it was a massive improvement. And I'm on to Natasha. I can take a break and catch my thoughts.
So I'm going to refer to my cheat sheets a wee bit as well. As introduced, I'm Natasha. I currently work on Medical 2. I'm currently a CNM1 in Cavan General, and I've been involved in the digital line use since the pilot in March 2020. So I would have been involved as a staff nurse first. And I suppose I was very happy to get involved and have been involved in similar systems in other hospitals. So I would have worked in England and in Northern Ireland, which would have had similar systems, but not tailor specific as this. They would have common aspects, but I was more than happy to help drive this, not only just put Cavan on the map, but also drive digital and electronic digital-based documents, which is being used in a lot of other hospitals. So I was very willing and keen to drive this. So I'm just going to go through the next few slides, and there is bullet points there, but I've just got some more information. So first one is the overview of the patient at the nurse's station. So very similar to the demonstration model that's outside, we have at the nurse's station the same monitor that's on the top at our nurse's station. So with having this, it's made it easy to access the data. It's frequently used in the morning by the doctors to see the previous hours of observations for the patients. It's also used with the nurses as well. As for me as a CNM, it gives me an oversight of the patients and also help to prompt or complete observations that might need to be next due, or just to help the girls out as well on the ward. With this, some people might have maybe received some of our early warning scores. we can print off from the central monitor station. It's colour-coded the exact same way that the paper chart is. So some of our feedback from other hospitals that we have got is we have patients that go for vascular appointments, go for cardiology, cath labs and things like that, but we got a feedback from the Mater Hospital that had a patient that was actually going for a long-term stay. And on our nursing handover that we do, our transfer letter, it'll ask for the last clinical observations on the top of it. But one of the nurses rang back and said, thank you so much for sending on the early warning score. Now, I know we normally would photocopy the early warning score and still send it anyways, but you're an A3 sheet, you're photocopying it, it could be black and white, you have your error rates where your numbers and your people do arrows, do dots, do things differently. But she rang back and said, thanks very much, because it wasn't just a snapshot of one clinical observation, it was a timeline of their observations since they've been into hospital. So it was great feedback to get back from other hospitals. So some people might have seen them if we've received patients from Cavan General. Our second point is just to remember when the observations are due. So completing a full set of iNews observations is an essential element of the patient's assessment, and the digital iNews has improved accuracy and efficiency. It supports and assists staff to comply with the iNews and the news protocol through prompts, open in context with the early warning score, and part of the track and trigger element of iNews. The early warning score is recorded on admission and therefore to provide patients baseline. So in Cavan, the way that we do our early warning score, patients come in through our ED services or AMU services and they have a wristband. So this might be repetitive from the demonstration, but patients will have a wristband and it has a QR code on the corner of the wristband in Cavan. And when the patient is admitted onto the ward, we either use their MRN details or we will scan the barcode on their wristband, and the patient's details will come up on the system, and we will do the observations that way. So that's how we will essentially put them on the system that way. So an ease and oversight of patients under their care. So patients can be assigned to the staff nurse looking after them for or the consultant. So for myself, if I had 6 to 8 patients, I can come in the morning. On the left-hand side of the screen, you can assign your patients. You can type in your name, so Natasha Riley, and when my name comes up, it gives like a plus box. So I can either drag across or allocate the patients that I have to look after for that day. So I don't have to look at the whole overview of the ward, I can just look and focus on my 8 patients that I have. Vice versa for a consultant, so if Jerry was the consultant on the ward, he could come in and he could type his name in and he would have his patients tailored specific to his name as well. So you're not looking at, again, all the overview of all the patients on the ward, but tailored specific to the consultant or to the nurse. The patient's data is available on any mobile monitor, not only enabling bedside access, but access anywhere it's needed. And again, at the central monitor station, but as Jerry explained, we have 5 monitors on our ward of Medical 2, and it's the same in other wards. So we have a monitor for every bay, and then we have 4 side rooms, and we have a monitor in every side room as well. Nurses use the mobile monitors to write up on their patients' notes with accurate observations, and also use them in handovers. Similar to the safety pauses, we have our safety huddle in the morning. We also have a safety pause then as well. So we will use them then in our clinical handover then as well for in the morning times and in the afternoon, in the evening time for changing in duties. Also, if patients are being transferred for another ward, the staff from the receiving ward can also view the early warning score from the central monitor prior to the patient being admitted, and there's just continuity. So if I moved a patient from my ward from Medical 2 to Surgical 1, the continuity continues. Same early warning score, the same digital early warning score applies. It continues on. Point 4, just ability to see trends of observations. And I think this is a big thing that a lot of the consultants have liked, is that instead of seeing like the dashboard, as you'll see on the demonstration, where it'll have the whole observations recorded, you can just click into the chart. And a lot of the consultants would like to see the chart more so than anything else. So they can see the exact trends, graphs, figures. They can see the trends of the temperatures, they can see the change of the heart rates. So that definitely was one big plus that we got from consultant feedback and registrar feedback. So as I said, some people don't like to view the dashboard, would rather see the early warning score as it would be in the paper format and see the trends and peaks, especially the medical team. And the MDT, some of the multidisciplinary teams and the physios would also like to see the oxygen saturations and things like that. As I said, people document differently, so arrows, dots, broken lines. Some use numbered, some don't use numbered, so that also helped in our auditing that, like, for our accuracy. It became more accurate and easy to use, see and follow. So it aids clinical judgment. It's kind of repetitive from Mary and the girls speaking. Like, so we have our Think Sepsis prompt that will come up and flash up on the screen. It also has the benefits to commence a sepsis protocol, the cues for caution, your own clinical gut judgment, and contact and escalate using the SBAR to doctors and commencing. And also just prompt from on the nurse's side that there's an awful lot that can be done, awaiting escalation, waiting the doctors to come. So you do your bloods, your cultures, you can do all. It's a prompt to start at ward-based and nurse-based level first. And then it removes manual calculation, and all observations are time-stamped. So this means that the calculations for the early warning score are accurate every time, and poor handwriting is no longer an issue, which is a big thing. So one thing that we did notice, so if there was an issue with a patient's early warning score, you would see the initials. You'd be tracing forever to find out whose initials they were. Is it a nurse? Is it a physio? Is it a student? So when you complete a set of observations, you have your initials stamped at the bottom. So for myself, it'll be NR. If there's a HCA, a student nurse, or an intern nurse that completes the obs, if they score 0, a nurse doesn't have to approve it. But if they score a 1 and above, then a nurse has to approve it. So you will have a 2 countersign. So if Jerry Dignan was the student nurse or the HCA, it'll have JD as the first signature, but it'll have to have NR as the second signature. So you know that they have been approved. Observations have been viewed by a nurse. So there's the countersign and approval there. It is important. It has improved our metrics regarding date, time, and etc. We've improved in GDPR 100% as we don't hold patients' information at the bottom of the bed. All observations are recorded and secured. In Cavan and on our ward specifically, we actually don't keep any of the care bundles at the end of the bed. They're outside the ward, along with our medications. So there's actually nothing kept at the bedside at all. It's all outside. As the monitor goes on our ward rounds to patient, so everything is there. Jerry might be stealing some of his information on his other slides, but we also have our lab lookup and things like that. It's all to the patient at the patient's bedside. Staff save time as it is no longer required to manually fill in and record parameters and calculate a score using a paper-based system. It gives more time with the patient and not to get distracted while having a manual input the information on the paper-based also. So I think that was a big thing that, if you're talking to your patient, you're getting to know your patient, but you can easily get distracted. You could start filling in on the big A3 forms that they are. You could start on the top and end up being on the bottom of another side as you continue on your observations. When we piloted the digital INUs, we didn't have resistance. We've been asked that question a few times, is how did you implement it? How did you get your nurses to go with it and roll with it? I was all for it when it started on our ward because I said I've used similar systems before. But it wasn't even a resistance. Nobody likes change. Nobody likes to do something different. But especially during the COVID when we started in 2020 and then when we merged onto the INUs V2, we had to go back to paper-based when we had the cyber attack. We could not wait to get back to electronic. We were asking Jerry, what can we do? Like, can we have our own Wi-Fi? Like, what can we do to get back onto the electronic warning score? So even from the couple of months that we were using it, when we didn't have it, we just realised how much we really did need it and how really well it works. Personally speaking, from a CNM and from a staff nurse, if you don't have your backing of a ward, if you don't have your backing from your nurses and your healthcare assistants, yes, you're CNM and your DONs and your ADONs and practice development, but if you don't have it from your nurses and your healthcare workers, it's not going to work. You need it from the ground, and they're the ones that's doing them. Your consultants, yes, from a question earlier on, when you're trying to get your consultants, it is going to be an issue. And there is a lot of learning still around this as well. But if you have your healthcare assistants and nurses at the forefront of this, it will work. So Jerry already showed the central monitor side. So this is based on Surgical 1. It's on the forefront, actually, of when you come down on their corridor, it's right in front of you. You can't miss it. You walk by it to get notes. You walk by it to get your medications. So it's at the forefront, and it's there. It's prominent on the ward. It's done in, as I said, the dash. People have probably seen the demonstration model, but it'll have 12 patients on at a time. It can hold up to 42 patients, if I'm correct. So our ward is a 32-bedded ward, so it has that extra leeway if you've forgotten to discharge patients, that it's there. Sorry, one thing I did forget to mention is, when you do print off for your early warning score, print it off to go to tertiary cares and stuff like that, we print them off. It prints off in colour and it goes into the notes when a patient is discharged as well. But the central monitor just gives you that little leeway. If you forget to discharge your patient, then they're still on the monitor and you can discharge them afterwards. I think it lasts for about 10 or 12 seconds. It's alphabetically ordered as per their surname, and then it'll move on to the next, and then so far on to their patients. As you can see, that's just a wee bit of staff feedback that came back from, I think, mainly our ward. So the central station is frequently used, morning by doctors to see the overnight observations. Calculated INUs is always accurate. Saves time, so they're not looking for charts, no longer having to fill in, manual or calculate the score. It's excellent, intuitive and easy to use, and that's coming from a staff nurse. easy to access data. It's improving our metrics, which is always a big thing. With date and time, it helps more timely observations. And just the last slide, it's just about a study from a patient's perspective. So patient information is at the bedside access to other hospital systems for like the labs and the NIMS, which we are using. And it's great. All is to hand to the patient there. All their clinical information is all with them along with the early warning score. All MDT staff caring for the patient have access to the same information and comprehensive decision making, giving time back to the nursing staff for direct patient care. And this always brings me back to a comment that I got when I was a student nurse. I had time more maybe as a student nurse to sit and talk to patients, but the main element of your nursing care is actually sitting with your patients, getting to know your patients, talking to your patients. It can be anything from a laugh to a joke or just asking about how they are. So it gave that time back to nurses. Reduction in delay in observations. Deteriorating patients were always there, now they're able to identify them earlier and increase the quality and safety of the patient's care. So I'm going to hand you back over to Jerry to finish the conclusion.
I think I'll wrap it up there. I realise why everybody was afraid of the 5-minute warning before this. There's an electric fencer sitting here at my right foot. All right, so thank you very much.
Thank you so much, Jerry and Natasha, for the lived experience and the passion and the energised that you are from that project, really, which is inspiring, and for being a national leader in this, really, and we're all going to learn from your experience and your expertise, so we're very grateful to you. Now we'd like to move on now to our keynote speaker on this particular section. We're delighted to have Dr. Gregor McNeil, who's a consultant in intensive care medicine, initially working in Queen's and Nottingham, but laterally in the Royal Infirmary in Edinburgh. And more importantly, or as importantly, I suppose, really in his other role, is the National Clinical Lead for the Scottish Patient Safety Programme. And he's going to talk to us about learning from the Scottish Patient Safety Experience and Safety Programme. So we're delighted to have you here. Thank you.
Thank you very much, Michael. So, in the time I've got today, what I'm aiming to do is give you a bit of information about the Scottish Patient Safety Programme, where it's come from, what it's doing now. I'm going to ground this all in a case example looking at our cardiac arrest improvement work, and I'm going to use my own health board, which is NHS Lothian, Edinburgh, to talk about how we managed to achieve some cardiac arrest reduction, and I think that might be of interest to you all. And then I'm going to give you, lastly, a run through what we're looking at in terms of improving the work around patient deterioration in Scotland going forward. So, the Scots have been doing quality improvement for many years. You often hear that at conferences. So I'm going to use this slide really to remind myself that although we have been doing this for many years, we've still got a lot to go. Okay, there are always new challenges, and already today I've learned valuable lessons, and I'm not maybe the first Scotsman to learn valuable lessons in Dublin this week, and I have to say I'm hoping the lessons I learned today are less painful than those learned on Saturday at the Aviva by my national football team. You could even say that in terms of quality improvement, let's hope that we can see some improvement against Armenia tonight. I'm not so sure. So let's think about the why. You're all here because you're interested in patient deterioration. Now, I'm an intensive care physician, and some of us will have come into this work because of experience of patients who we felt should have been escalated, but maybe for whatever reason that did not happen, and that patient developed harm, and maybe the ultimate harm of cardiac arrest. Some of you, and I know you may have experienced this over the past 2 years, that you came into this work because you saw a patient getting inappropriate care at the end of life, the harm of useless CPR when a do not resuscitation order should have been considered earlier in their care. And I'm reminded of my better half, who's a general practitioner in Scotland, who often tells me before I leave for a night shift, and I don't know whose quote this is, heal the sick, comfort the dying, but don't get the two mixed up. And I think that is reasonably true. But we're living in challenging times, and if we think about the why of this work, certainly in my own experience within NHS Scotland, our health service is under huge strain. Even as we come out of the pandemic, we are dealing with staff who are burnt out, fatigued, and we've got nursing gaps, medical gaps like we've never seen before. ICU was very much the kind of the glamorous part of the hospital in Scotland traditionally, but we have huge nursing shortages right now in that area, and it means that we're dealing with a very challenging landscape. If you look at that in terms of a number of conditions, the way conditions are presenting right now has changed. We're seeing less and less patients presenting with sepsis to our hospitals, but the ones who are presenting later, they're sicker, and for the first time in over 10 years, we are seeing our mortality from sepsis in Scotland rising, not falling. And that's a huge worry. Any of you who are working in acute care, you will see the mental health burden of the pandemic. I'm sure it's similar in Ireland. Overdoses coming in, trauma associated with mental health issues, and when patients get into those hospitals, they're more likely to be delirious and deteriorate associated with that. And even if we look at our elective care, our patients are frailer when they go for major surgery, more at risk of deterioration. And that's all gets to the point that the landscapes, particularly in Scotland, because we've been collecting data on this for over 10 years, that was as predictable as the Wembley pitch is now more like a muddy field, such as the one here. Things are not predictable, and the landscape has changed. What I'm going to go on to speak to you about is improvement that we've seen in my own local hospital in Edinburgh. But I want to emphasize to you that the job is never done. And I'm reminded of a case example that I might just quickly share with you around this work. And the story is of Bill. So Bill was a 63-year-old man who'd had schizophrenia for many years. He'd had reasonably stable mental health with support of a community mental health team. But like many people with mental health issues over the pandemic, his health deteriorated. And he needed to go on a new therapy called clozapine. And as some of you will know, clozapine has some interesting side effects in that it can affect your cell count. Now, in that context, Bill presented one Saturday afternoon to the Royal Infirmary in Edinburgh. He'd become drowsy at home and his wife had become concerned. When he arrived at the hospital was heaving. There were ambulances backed out the back door. The department was massively over capacity, as it often is these days. I'm going to use news, and apologies for using that, but similar to iNews, his observations were taken. He was pyrexial, he was relatively unresponsive, and his news score was 6. A moderately raised score and consistent with a diagnosis of possible sepsis that was marked by the nurse on a paper chart. Some tests were done. Bill's bloods did indeed show that he was neutropenic. He had deranged clotting associated with sepsis, and his chest x-ray showed signs of consolidation, again consistent with sepsis. The diagnosis was made. It was made by an FY2 doctor, so 2 years post-qualification. We're all worried about Bill at this point, but the department is heaving. Bill is in a corridor, he's not in a bed space. And the nurses and the student nurses are running around trying to take the observations. The next set of obs, the news 2, is 5, and that's at 5 o'clock. He's been in the department a couple of hours. The problem is that there's an error. The news is not 5, it's actually 8. And that's because the person taking the observations has too many jobs to do, so an error occurs. And you can see as I go through this, so much of the work that we're trying to achieve in Scotland is mirrored with the work you're already looking at here in Ireland. So, what happens next? We recognise that he's got sepsis. We still advocate sepsis 6 in Scotland, so that is undertaken. We check his lactate. We're all really reassured it's less than 2. That's great. But now we start to see the language that we see when a patient is undergoing failure to rescue. IV access is difficult. That's recorded in the nursing notes. We all know what that means. We can picture Bill now, can't we? The FY2 is unable to obtain the blood culture, so in actuality, the sepsis 6 is not completed at this point. And there is no senior review of Bill, or certainly it's not recorded. We imagine a registrar running from trolley to trolley, giving basic advice, trying to do their best in a system that is overloaded. Bill's news too remains high. And as we often see when we interrogate news or iNews charts, as the score gets worse, the errors mount. And some of that is just basic error, but some of that is an overburdened healthcare provider trying to almost maintain the score at a certain level because they're just struggling with the number of plates they're spinning at that point. We then see the next challenge, the transition of care. The transition of care from the emergency department to the medical receiving ward. Again, an opportunity, as you've heard already today, in terms of safety huddling, but also a risk that there's further loss of transfer of information. His news too remains high at this point. He's now been in hospital 7 hours, and there's still no documentary evidence that's been seen by anyone more senior than a junior doctor. The nursing staff clock that he looks sick, and they escalate to the medical staff immediately. And then we see the next thing that we often see in these patients' case records when we're doing adverse event analysis. Patient commenced on oxygen, patient not tolerating oxygen. We know how this goes. Bill's nurse gets it. You can see that from the nursing notes. She does her individual bundle of care that she can do within her power. She contacts the family, or at least attempts to. The news too remains high, and Bill's case is discussed between the junior and the registrar on for the hospital, because now it is the evening, the out-of-hours period. And they agree to escalate to ITU if Bill deteriorates. What deterioration looks like from this point of critical illness is not discussed. 1 a.m., still not keeping oxygen on, so sedation is administered. Dearie me. The registrar at 2 a.m. is attempting to see Bill, but still cannot get to him because of the acuity on the rest of the hospital wards. There's no sign of a consultant at this point. Bill's stats start to drop. This is ironic because he is now keeping his oxygen on. And Bill vomits. A medical emergency call is put out, and finally the registrar arrives. But by the time she arrives, Bill is in cardiac arrest. Now, CPR is commenced. And the miracle about Bill's case is Bill gets return of spontaneous circulation and goes on to spend 3 months in critical care. And Bill survives. And Bill is at home now. And he is weaker than he was before he came into hospital, maybe if it was going to be forever thus. But he did survive. But that is not the usual outcome in such a scenario, as you all well know. And I use that to ground what I'm going to tell you next, because the challenges continue. And I don't have time today to give you data, but these are the kind of the beliefs I have in this work going forward, is that inherently reducing cardiac arrest saves lives, obviously. Recognition of acute deterioration earlier saves lives. Having a standardized response to deterioration, I'm very interested in your AMP work, saves lives. And safe communication across care pathways or within your own location through huddling saves lives. And leadership, and clearly the leadership that you've got in your own healthcare system to support a culture of safety at all levels saves lives. Okay. So how does that look from a Scottish context? Well, again, I don't have time to explain the vagaries of the organisation of healthcare within Scotland to you, but suffice to say that Healthcare Improvement Scotland is a large umbrella organisation that does a lot of stuff, whether it's medicine regulation, clinical guideline setting, antimicrobial stewardship. But my part is the bit at the bottom, the Scottish Patient Safety Programme. It was launched in 2008 in a collaboration with the IHI, And it was initially launched around acute care, but it's expanded to look at a number of different areas. It was launched in my hometown of Dundee by a health minister called Nicola Sturgeon, who ultimately is still our boss. And it was aiming to improve the safety and reliability of care and reduce harm. And it was initially launched in acute care. And the bit about it was using collaboratives and data, anchoring it all with data. And the data we looked at and still look at now is cardiac arrest data within SPSP Scotland. And over time, the SPSP collaboratives have shown a reduction in hospital mortality across the period of work. We've looked at a number of things through acute care in SPSP, such as pressure ulcers, sepsis, but now we have two main focuses: falls, and my colleague Lara Mitchell is the clinical lead for that, and deteriorating patients, which I lead. And how do we structure that improvement? Well, we launched collaboratives. Our latest collaborative was launched in September last year, just coming out of the pandemic. And we have a structure in place. In every health board, we have 14 in Scotland. We have a local SPSP program manager. And we have a clinical lead for SPSP and individual clinical leads sometimes for deteriorating patient work. And that drives forward change with a local steering group, much as you've heard examples within your own health system today. What do we do as part of HIS and SPSP? Well, we underpin that work. We provide measurement tools. We ask for some data. The only data we ask for is cardiac arrest these days, but we provide information on other measurement tools that boards can use. We host webinars, we share network events, and we share case studies. These are my own pictures of my own local leads in Lothian, Dr. Nikki Moran, whose work I'm about to talk about, and also our SPSP program manager, Caroline Swift, whose work I'm going to talk about shortly. And this is our driver diagram. And it's an adaptation of the previous acute care driver diagrams we've had in Scotland. We've always looked over the course of the programme at a reduction in cardiac arrest rates, and the only difference is this time we don't have a number in that reduction. There's a number of reasons for that, but many of our boards paused collection of cardiac arrest data over the course of the pandemic. So that number is not yet on there, but we are looking for a reduction. And all the various programmes of work we have within that driver diagram are driving to that overall goal of reducing cardiac arrest rate within acute care. And we provide our teams with a number of measurement tools. The one we want to hear from them about is the cardiac arrest rate, but they have a suite of other scores that they can use and measurement tools to improve patient care, as well as some balancing measures there as well. And this is what the programme managed to achieve in the time before the pandemic. As you can see, it wasn't every hospital in Scotland at that time. It was only 17, but there was a reduction in cardiac arrest over time. And I would put it to you that you do need that ultimate outcome measure to drive improvement in your system. Cardiac arrest, unplanned cardiac arrest, or unanticipated cardiac arrest, as you've defined it, is the end game of deterioration, hence the picture of the end game there. So you need that focus to drive this improvement work. Certainly that's what we found. So I'm going to talk to you about a local case example from NHS Lothian. That's my own small patch on the bottom left there, the place with the helipad on the building there. That's new. Glasgow got a helipad, so we had to have a helipad in Edinburgh. So if we look back at about 2018, we'd been running SPSP relating to cardiac arrest work for the whole time SPSP had been running it. And in our own patch, we had this run chart, which essentially showed not very much. So no change in our median data at all. So we had to think about how to change this. And what we used was a quality management system. And you may have heard about quality management systems within your own work. And it's something often led by our improvement teams, but also with clinician buy-in. With a quality planning phase, an improvement phase, a control phase, and then back to planning again. I'm going to show you what that looks like from an improver's point of view and also from a clinician's point of view. So in terms of that planning phase, for those of you who've looked at quality improvement, you'll know about Deming's concept of lens of profound knowledge, but it's about knowing your system. So when we started this work, or revised this work in 2018, we did a big systematic review of all our cardiac arrests over a prolonged period of time. And we went into great depth looking at each of them and trying to identify common themes. The reviews were led by the people that know these cases. So clinicians like myself, yes, but also education team members and resus officers in our hospitals, the ones that really know the granularity of the data. We fused that with staff questionnaires from our baseline wards, from the staff who had to take the observations, and we looked at the variation in their practice, how they're taking observations, how they're escalating care. And we used all that to create our own bespoke local driver diagram, and it had data in there that was pertinent to our local acute hospitals, slightly different, more modified from the national work, but mirroring it. And when we got into the quality improvement phase, at that ward level, we encouraged teams to own their data, to have their own individual project charter, and to own their own change ideas and also their run charts with data. There was commonality of themes between, for example, the acute surgical and medical ward, but there were also subtle differences. And what we really did is we drove that into the management structure of the hospitals as well. So we defined how we wanted our consultants to review their cardiac arrest cases. And if they had a cardiac arrest, we wanted to own that cardiac arrest and work out what happened and work out what they wanted to do next time. But within every management meeting within our hospitals, we wanted the cardiac arrest to be discussed. And over time, we saw a reduction. And although interestingly, we saw a big reduction initially in the pandemic, between waves of the pandemic, we did see a rise in the cardiac arrest rate. But now, right now, this run chart ends in January, but since then we've managed to maintain stable data around 0.8 cardiac arrest per 1,000 discharges. And that's pretty low, and we're happy with that. But we're not satisfied. We still have, as you saw with Bill, bad things happening in our hospitals. And we're looking at the next way in which we can interrogate data. Not so much from cardiac arrest, maybe more looking at our medical emergency calls, what's happened with those, and also our serious adverse events, because we know there's granularity there, learning about how to improve further with patient deterioration. So that's all quite QI heavy, but how did that look from a clinician perspective? Well, when we did that deep dive into planning, we understood from a clinical perspective our system, and it kind of, when I remember doing this, some of my biases kind of held true, but some didn't. A lot of our patients who had undergone CPR, when we looked back, they had many health conditions and they were at the end of their lives and they shouldn't have had CPR. That was not a surprise to me, and I'm sure that is an issue you face in your own practice. But I actually thought, as an intensivist, we were always getting calls from wards where patients had not been discussed with the specialty consultant. But actually, the data suggested that actually our physicians, and I speak as a physician, and actually even more so, our surgeons, which slightly annoyed me, were good at looking at their patients before referring to critical care. Okay? So we didn't really focus on that when we did our improvement. Okay? When we collected data, it was key that our clinicians knew the granularity of the data. So the form on the left is our Lothian cardiac arrest audit tool. That is data collected by our resus officers at the point the patient has their arrest. So it's very good data, and we use that initial data to drive most of our run charts. The review tool on the other side there is the review tool we asked our consultants to do when they had a cardiac arrest. That deep dive into why this happened and what they could do differently next time. We asked them to share that learning at our local mortality meeting. So really, any individual consultant in the hospital wouldn't have that many cardiac arrests in any one year, but they had to own that cardiac arrest. And we found that really helped with clinician engagement. But we engaged it in everything else that we did. We used our site safety huddles, our organizational huddles to highlight deteriorating patients in a way that we hadn't done before. And when we implemented News 2, as opposed to News, we used it as a way to highlight the deteriorating patient again, with escalation boards that we have in all our wards to identify who to call when the patient is deteriorating. And the key thing was sharing data. And these site reports on deterioration were shared with management team, sure, but they were also shared with clinical staff so they could understand where they had to improve and understand their own data and understand things like, as the cardiac arrest rate went down, the medical emergency rate went up. That's an okay thing. It means you're being called to see patients who are still alive as opposed to dead. That's good. So they understood their data. And actually, we, as a clinician, as an intensivist, I like KIT. And we found some interesting offshoots in this project in that because we understood exactly what was happening in cardiac arrest, we were able to use that data for other ways to get additional kit within the hospital. We worked out that many of our cardiac arrests involved difficulty in access, so we were able to purchase IO needles for every cardiac arrest trolley, end-tidal CO2, automated CPR devices, the Lucas here, to position them around the hospital to unburden staff when doing CPR, okay? Because the other thing we found is as the number of cardiac arrests went down, the patients who were having cardiac arrests were younger, potentially more salvageable. And that last panel there is our ECMO CPR team, and we're looking at using that not just in our out-hospital cardiac arrest, but also our inpatient ones as well, because the cardiac arrests that happen now are those ones that you really do want to salvage, okay? And all of that has meant that we have managed to maintain our improvement going forward, okay? But it's been hard fought. So just to wrap up, where are we going now in terms of quality improvement into patient deterioration across Scotland? Well, there's much to be done, and certainly I've learned so much today in terms of things I can take away for a Scottish context from what you've already spoken about today. We're looking at a number of things: reliability of data, structured response, treatment escalation planning, sepsis, and EOBS, to name but a few. We've not publicly released a lot of our national cardiac arrest data since we restarted our collaborative in 2021, and one of the reasons for that is reliability of data. Some of our boards have been collecting this information for many, many years, and they have reliable paper-based systems, but some don't. Some are still trying to get someone in the switchboard to mark down on a paper chart when there's a call for cardiac arrest. Some of our boards are moving towards electronic systems. Our Scotland-wide incident reporting system is called DATEX. And I think that's where we'll go. So that's not quite there yet, but we're trying to get reliability because we now have 13 of 14 boards reporting this data. Structured response has been a big challenge in Scotland over many years, that we don't have that structure in place. We kind of make it up as we go along when we're responding to deterioration. Many healthcare systems, it sounds like you're already doing this in Ireland, they're certainly doing this in England, Australasia, have a different type of response, whether it's an AMP-led critical care outreach team or a medical emergency response team. We've classically not had that in Scotland. We're really relying on our signed guideline for patient deterioration and the staff on the ward. That system has strengths because the ward staff know they have to own that deteriorating patient, but also has risks. So one of the main things that we've done this year is launch a structured response tool that allows teams to interrogate how they respond to deterioration and looking at the phases of response to the deterioration. That initial recognition, which is often good, that response and review using an A to E assessment, which is often good, but also tying in the reassessment bit. What happens if the interventions you did initially don't work? And we're rolling it out, that out across all our boards. And we're using SIM to try and look at how we implement that as well. A major problem in Scotland over the pandemic has been around anticipated care planning and treatment escalation planning. And obviously we had to do a lot of this work very quickly when the pandemic started. And some of it has gone okay, but some of it has not gone okay. many of our primary care physicians were tasked with calling up their patients to discuss DNA CPR on the telephone. That was less than ideal. And a lot of us are quite bruised by that experience, and I'm sure that will be fleshed out more in our own COVID public inquiry that we're having in Scotland. But we're looking for solutions that are more patient-centred. And we're interested in the RESPECT tool, which I think you're going to hear about this afternoon. And many of our boards are looking at this in having a patient-centred approach to plan for deterioration and what a patient would or would not want. We're also looking at sepsis. So an important document that was published last month in the UK is the Academy of Royal College's report on antimicrobial therapy in sepsis. A lot of our sepsis improvement work over the past 10 years has been fantastic, but we have seen a steep rise in the use of antibiotics, and we're really challenged right now in terms of antimicrobial stewardship across the UK. So this was an ICU-led paper really saying, you know, if your patient's less sick or you're not quite sure they've got sepsis, you do have a bit of time before you steam in with those antibiotics. So this decision aid tool that's in the center of the screen there, that's something we're looking to implement across all our boards, but still maintaining the good parts of our sepsis 6 care for sepsis. And we've put out a position statement about that to make sure that our boards know how to approach with this. And again, you've just been hearing about a fantastic EOBS project. That's something we're trying to do in Scotland as well. Okay? I'm slightly jealous that you appear to be implementing things on a national basis. All our boards have been buying different systems, and it is some kind of show they're putting on, but it's difficult. So a lot of our webinar work over the next coming year will be looking about how you implement EOBS so boards can learn with their own systems that they purchased. So that was a bit of a roller coaster going through what we've done in SPSP, giving you that case study of the cardiac arrest improvement work across Scotland and our future work. But I would say to you that whatever you do, looking at that single outcome measure is a key part of what we've done, and that might be something you're thinking about as well. Thank you for your time.
Thank you. Thank you, Gregor, for a super lecture, and resonates to all of us, and taking Bill into the room, I think, causes shivers up our spine. We've all met Bill or Dave or Mary or Joan or whoever with sequential deterioration, which is not, the handbrake isn't being pulled really. So, and I think that's why we're all here really. So thank you very much indeed. Okay, I think we're reasonably close on time. I think we're not doing too bad actually. So I'm delighted to welcome our final speaker of this session. That's Professor Patricia Hughes, and she is employed as a regional manager for HICWA. And in addition to that, she's extensive background in healthcare improvement, executive management, nursing and midwifery. And we're delighted to hear her speak today, and she's going to speak on the topic of the deteriorating patient and the assessment judgment framework. Thank you very much.
Thank you, Mike, and thank you, everybody. And it is lovely to be here today, and thank you for the invite to share with you HICWA's approach to assessing how hospitals are implementing the quality improvement around the deteriorating patient. So the aim of the session is to outline HICWA's monitoring programme and to explain HICWA's focus on the deteriorating patient. I'll do this by outlining HICWA's approach to monitoring to date, identify the key drivers for the change in our monitoring programme, and I'll refer to the guidance document, the assessment judgment framework, which was just published there a couple of months ago in relation to the deteriorating patient improvement programme. And there'll be an opportunity at the end, I think, for some questions. So you're all familiar, I expect, with the work of HICWA in setting standards and monitoring standards. And heretofore, the approach has been either proactive a mixture of proactive and reactive, or totally reactive. And just to give you an example, examples of our proactive work have been around thematic monitoring against the national standards. And the national standards I refer to are the Safer Better Healthcare, which were published in 2012. We haven't reinvented them, they're principle-based standards. And in the past, HICWA has undertaken monitoring programs around infection prevention and control, medication safety, antimicrobial stewardship, nutrition and hydration, and the maternity care program. It has also been involved in a mixture of type of proactive, reactive work, where it has carried out governance or assurance reviews, an example of which would be the ambulance services, the University Hospital Limerick review, and the follow-up assurance review to the Midland Regional Hospital services at Portlaoise, and also the ambulance services. And then examples of the reactive work are where we have undertaken Section 9 statutory investigations, such as that undertaken in UHG following the death of Savita Halappanavar. So why are we changing, and why are we changing now? So just to give you an example, there's about 90 hospitals under the remit of HICWA. That's about 50 acute hospitals, give or take, 1 or 2, and the rest are rehabilitation and community inpatient hospitals. The thematic monitoring has sufficed to a degree, but we need to get around more hospitals more quickly and carry out assessments across a wider range of standards. Also, with upcoming legislation, and Orla referred to it earlier this morning, the Patient Safety Bill, the Human Embryo Tissue Bill, there is going to be mandatory reporting around notifications of serious reportable events. So we're going to have to respond to them in a more agile format. And also, that will bring in the private hospitals under our remit, plus other healthcare providers, which the number of yet has to be estimated. So the workload for HICWA is going to grow exponentially over the coming months and years. So our new monitoring approach on the same 45 standards from 2012 has been devised to increase our agility, particularly around the monitoring of those, monitoring compliance of those post-pandemic, but it also enables us to adapt to the new and expanded role arising from the Patient Safety Bill and the implementation of Sláinte Care. It will also help us integrate our own new ICT systems, which we use, one of which we use is PRISM, and like what everybody's doing in the HSE and in the voluntary hospitals, constantly trying to improve our use of business intelligence, the collection and the interpretation and the usage of data to drive improvements. And further down the line, it will help HICWA prepare for licensing of hospitals in the future. So some of the challenges we faced in considering the work that's in front of us and our response to change, where the Patient Safety Bill will involve short notice inspection across a broad range of risk areas. And so for that, we have published a guide to an assessment judgment framework against the 45 national standards. That guide is now ready for use across a bespoke range of risk inspections, and it's on the website should you wish to refer to it. In terms of our previous inspection types, these would not be transferable across the different settings, including the private settings. And so, again, a core assessment of 11 standards has been chosen. So out of the 45 standards, we've devised a programme to look at specifically 11 standards, which crosses a broad range of patient care. And this is applicable across any healthcare setting, including the private sector. But it still allows us to use other standards from the 45 to assess compliance. And finally, conducting multiple thematic programs was not scalable, and that's why we have developed or devised this single approach which can be applied at scale on a regional basis. So just to summarise there's 45 national standards. We're concentrating on 11 as we devise this new programme. We wanted to balance the patient experience with compliance with standards. And as you'll know from previous HICWA inspections, those of you who've been close to the front of those, you'll know that we always talk to patients or people using the services as part of the inspection. However, we're now lucky to have the findings from the National Care Experience Surveys Programme, the National Inpatient Experience Programme, surveys, and the National Care Maternity. So there is a considerable amount of validated data. So we are using that data now, the comparisons and the trends, as well as on-the-spot communication with people who are using the services in the hospital during the inspection to guide and inform our inspections. And we want to see if the patient experience is reflected in compliance with standards. So I will be coming on to the deteriorating patient programme in a moment, but just to give you the context. So the 11 standards we've chosen are from 5 of 8 themes. You'll all remember that big wheel that HICWA used to sending out the 4 above the line and 4 below the line. So 5 of the themes have been picked and 11 standards from those. And the standards we are looking at are centrally around the patient experience of person-centred care, the leadership, governance and management of any setting, so be it ward, be it the DPIP, be it the hospital, the effective care, the safe care, and we're also looking at workforce. And particularly what we're looking at in workforce is around support of the workforce. And psychological safety came up a few times here this morning, and just culture, and that's something we'll be zoning in on. So in terms of the PCC, the person-centred care, we're also looking at a human rights-based approach. You'll be familiar with the FRIDA principles. And as I say, we're drawing from the National Care Experience Programme to guide and inform us on that as well. We're looking to see, is the care effective? Is it evidence-based? And is this being monitored? So when we come to safe care, there's a whole load of things we could look at, but we have decided to look at safe care through the lens of 4 particular areas: infection prevention and control, medication safety, transitions of care, and the deteriorating patient, including your early warning systems and the identification and management of sepsis. And as I said, we've talked about workforce and also the governance, leadership and management, and that's at every level. And to guide you and to guide us, that publication is available on the website, published in April just gone, and that gives you lines of inquiry or examples of descriptors of compliance with the standards. So I won't go through the standards, but you know what they are. You're all familiar with those. Those are the 5 themes and those are the 11 standards. But we're looking at the person-centred ones around patient privacy, dignity and autonomy. And listening to our previous speaker, the issues around overcrowding, we're all very familiar. It's in the news every day. That's an issue for people who use the service, for staff, and obviously for people like in HICWA who are monitoring the services. Culture of kindness, consideration and respect. The complaints and concerns, how those are managed, responded to promptly, openly and effectively. We're looking at effective care, and the 2 standards we're looking at there are around the physical environment. And again, we would all be familiar with how our hospitals may need improvements in the infrastructure, in the physical infrastructure, but also in how well it's maintained. And also we're looking at monitoring. And again, this point was raised this morning: if you don't measure it, you can't monitor it. So that's very important. And these all apply to the deteriorating patient as well. And then under safe care, we're looking to see how providers protect patients from the risk of harm through the design of services. And many of the examples people have talked about here earlier today are really good examples of how you're designing to prevent the risk of harm to patients. And then how providers effectively identify, manage and respond and report on patient safety incidents and what's done after that. And then under leadership and governance, we're looking at formalised governance arrangements for the assurance of high quality, safe and reliable care. We're looking for effective management arrangements. And again, we've heard some examples, and we all know them. They've all happened in all hospitals where we work, where, you get an approach, but you need a more unified approach. You need to get the whole team involved. And that's really important. That's what HIC will be looking at, that there is multidisciplinary input, and that happens from floor to board and board to floor. And finally, that you have systematic monitoring arrangements to identify opportunities. And finally, the workforce, supporting the workforce. So, how am I doing at time? 5 minutes, okay, that's okay. So the inspection cycle that we're rolling out is going to be every hospital, every acute hospital will have at least 2 inspections in a 3-year period. I want 1 announced inspection followed by 1 unannounced, and there may be more than that if there are any triggers. The approach is floor to board, so those are the standards we'll be looking at in each of the areas. And I know Blonage and Evelyn are hoping to get these slides made available to you afterwards, so you'll have those. So how will HICWA assess compliance? So as I've said, we've referred to the guide, but our assessment of compliance is carried out through observation, communication, and documentation. So we observe the clinical areas or the areas that we're in. We talk to staff, we talk to people who are using the service, and we review the documentation. I would say there's going to be less of an emphasis on going through loads and loads of policies and more emphasis on seeing, hearing, observing, and talking to people. We want to see that what's happening on the ground and what people are experiencing is compliant with standards. So I'm going to go through these quickly, but those are the questions that we're going to ask. Are patients and service users experiencing person-centred care? And we're using human rights-based approach, the dialogue with patients, observation, and exploring their experience. We'll be looking at the physical environment, and we'll be looking to see what monitoring arrangements are in place, and we'll be exploring the effective care. For safe care, we'll be looking at the experience from the existing programs. We have a lot of information from medication safety and IPC, so we'll be bringing that. So we'll be looking back at previous inspection reports for various hospitals and seeing what was meant to be done and has it been done, has it been followed through. And also the response to patient safety and evaluating the 4 key risk areas of harm. And we'll be looking to see how well the service is managed. Are there governance arrangements? Are they effective? And is there systematic monitoring in place? And does that go on? Is the circle closed? When there's a problem, is it identified? Is there a plan put in place? And is it acted upon and measured again? And then the workforce, I've spoken about that already. Protected from violence, bullying, just culture, good working conditions, EAP, etc. We all know there's been lots of burnout through the pandemic, etc. So the assessment judgment framework we've developed, the purpose of that is to support service providers and HICWA inspectors, gathering evidence when monitoring and assessing service and making judgments on compliance. And it sets out examples of the lines of inquiry to be explored by inspectors, and it outlines the judgment compliance level, which we term compliance descriptors. You'd be familiar with those. It's either not compliant, partially compliant, substantially compliant, or compliant. That's the report. You'll get it on our website. So in relation to safe care in the deteriorating patient, the standard, as you know, states that service providers protect service users from the risk of harm associated with the design and delivery of healthcare services. And what we're looking at there are there systems in place to identify and reduce the risk of harm associated with a delay in recognising and responding to people using the service whose condition acutely deteriorates? Are there policies and procedures and guidelines developed and implemented for early detection and emergency response for patients whose condition is deteriorating? So we'll be looking at those kind of things. So the implementation of the DPIP programme at hospital level, the use and as intended of the early warning systems, the use of your approved charts, your IMUs, your iNews, your PEWs and your eMUs for the various cohorts of patient, irrespective of location. The identification and management of sepsis, your training, the auditing of SAME and the learning and completing the full circle. So I won't go on through that. I've just explained all that, but this new monitoring is designed to achieve our aim to ensure that care is person-centred, safe and effective, with the primary focus on the patient. Starts with the patient and supports them. and will work across the spectrum of services. So the next step is we've just piloted this new system and we've carried out pilots in a number of hospitals. We've also done some risk-based inspections, and it's will be rolled out now from the end of this month across all of the hospitals in the health service. And we will be publishing reports from the pilots. Beg your pardon, we don't publish the reports from the pilots. We will be publishing reports from all of the hospitals hereafter, and that will give a view to the public of our assessment and will provide learning for our services and our expectation. So just a top line, the current status of management of the deteriorating patient. From the limited inspections we've carried out in the last few months, we can tentatively acknowledge that the oversight management of the deteriorating patient is developing in acute and community services. We are placing emphasis on the leadership, governance and management and the involvement of the MDT, and I know that's come up earlier here today. And with our inspection approach and the work of the DPIP, we believe that the two-pronged approach through monitoring and quality improvement will embed this further in all healthcare settings. And we want to support the work that you've been doing in seeking to improve care for patients. Thank you very much.
Thank you very much. We'll just do a quick time check, and I know you're all hungry and want to interact a little bit. So we have about 5 minutes really for questions, and very interesting session really that we had, the sort of very organic on the ground approach, obviously at a hospital level, supported by national, and then the patient-wide Scottish patient safety strategy, and then the regulatory side of things, obviously meeting in the middle. Do you know, I mean, quality improvement is one methodology, but regulations is the other. So we'll open the floor to questions before we go off for a bite to eat. We have a number of roving microphones. We have a question here in the front, is there?
Thanks very much to all of you for excellent talks. My name is Nigel Salter. I work as an emergency medicine consultant in Dublin, and I have been part of a group advocating for a cardiac arrest audit and register. So very much welcome your comments, Gregor, in relation to a need for this data and the importance of this data for quality improvement. I think it's important for our audience to be aware there's been a lot of work done for a number of years here in Ireland to advocate for this, and it's been fantastic having Aveline and DPIP to finally have a home for that sort of project as part of the HSE organisation. But I think it's also important to say that in 2022, we don't have funding for such a project in Ireland, and it's disappointing to say that. But very much welcome your comments regarding the importance of this if we're going to drive quality improvement in this whole area. My question is, in terms of the data we've seen, there's clearly a benefit in terms of the incidence of cardiac arrest. I guess the bottom line is, does that translate to survival, and do you have any data on that from Scotland?
Thanks. I mean, I think that's a good question. The SPSP programme as a whole looks at standardised mortality rates within hospital setting. And I think we have seen improvement with that, as I mentioned. The latest data, I think from the pandemic, it's too early to tell. But I think it's important to say that the one caveat is you need to look at your cardiac arrest rate and your reduction in the context of your overall hospital mortality rate, because clearly you can game the system. You can put everyone do not resuscitate, and then you look fantastic. And I'm not suggesting you do that. But yeah, it's important to know that data within the context of your standardised mortality rate as well.
Gregor, not to put you under pressure, just the RESPECT tool, can you just tell us a little bit about that?
So the RESPECT tool, which I think you've got a session on this afternoon, is a tool that has an evidence base around about it, published by the UK Resuscitation Council, looking at a patient-centred way to talk about treatment planning, whether that is CPR, or in some ways, more importantly, from my perspective as an intensivist, what are we going to do to you in life? Are we going to take you to critical care? Are we going to put you on a ventilator? Is that something you want? Is that something we think you would benefit from? And having that conversation out there before you get sick, or still having it as you're deteriorating, either you or your family member, and then you as the patient own that form. Some of our boards are looking at that and implementing it both in paper-based and electronically, and I know a number of trusts in NHS England are also looking at that.
Question at the back, or halfway down.
Hello, thank you. Barbara's my name. I'm from ICU Steps Dublin. We're a support group for patients who have come from critical illness and families as well. Natasha, your words really rang through, saying giving nurses time to be back with the patients at the bed. In all of this, our patients, of course. Bill's story, you know, he survived, he got home. God knows what Bill is going through out now. He may be looking for support outside of. So it's not just about saving a life, it's about getting everyone on board to begin with. And I guess my question, with maybe a comment, is how do you get the staff who are bedside on board? These are the advocates. The junior staff are probably the best advocates for every patient. They see and hear everything. And how do you encourage them or let them know that you trust their instinct? Not just them, that you actually trust it. So when you have those meetings, that they're allowed to say, I'm not really happy about something, but the numbers don't add up. So just from very early moment, just get everybody involved and give them all a chance to speak for that patient, because they're the vulnerable person in all of this. And thanks for all your endeavours. Thanks.
Thank you. There was a wonderful picture that you showed, actually, which was the clarity about the early warning score and the absolute chaos of the notes in front of it, with the secrets and folklore or chart lore and various stories. Was it his left hip or right hip, or just we don't know? We've forgotten. We don't care anymore. But actually, with the sign, which just really, it's a very powerful image. A very powerful image. I might just ask one question, Jerry. I mean, one of the issues really with latest, you know, there's doctors and nurses here and others really, but one of the things that I become aware of this project actually is the pivotal importance. You're allowed the second most important poster boy of clinical engineer, Jerry. Ronnie McDermott be number one, obviously, but and I just how to be involved in a quality improvement project like this, and I know that you've been in a number of forums. It must be very gratifying, actually, that you see that technical aspect of your work materialising into patients and being celebrated.
It is absolutely brilliant, so it is. But the real feedback is from the staff in the wards. We don't get to see necessarily from the patients, but when you see the enthusiasm of nursing and doctors, we have two, Kieran Hannon and Paolo Pinero and Gavin, who are real advocates for the system as well and really engaged with it. And that's where we would see it, and that's where we get the kind of reward for it.
Yeah, absolutely. We're delighted to have you here. Okay, well, I think we'll close the session. Really fantastic session. Just so you know, the lunch is in the same, it's written down for you, I can read it, in the same location as the atrium, the boardroom, and actually we're going to come back at 2:05. And there is the demonstration outside as well of the vital signs automation. So thank you very much indeed.
There's a freedom within, there's a freedom without. Try to capture the lurch in a paper cup. There's a battle ahead, many battles are lost, but you never see the end of the road while you're traveling with me. And now, hey now, don't dream it's over. And now, hey now, when the world comes in, play come,
So I presume you're timed to a T, are you? Okay. I love the calm descending. Everything's really obliging. I don't have to say anything. I'm waiting for the instruction there from Blanet as to whether I'm to start. Hi, how are you? Oh, how are you? Do you want another chair?
Will I just sit down and I can come up?
Is that okay with you? Yeah, lovely to meet you, yeah. Will I go? Okay. Well, hello everybody. Absolutely delighted to see such a wonderful crowd today. Marie Lordan Dunphy is my name. I'm Assistant National Director for Quality and Patient Safety. I work with Orla Healy that you met this morning. Just to say that myself and Evelyn and the team have worked very closely over the last couple of years. This work is very close to my heart. I have a clinical background. I've worked in quality and patient safety a long time, and I was on the National Series Chair of the National Incident Management Team, and I saw, many incidents as well and oversaw them. So this work is critically important, and we're delighted to be able to support it. And I suppose only for all of you, this work wouldn't be happening, so I just want to acknowledge that and all the speakers here today and all the wonderful work that they've been doing over time. So, without any further ado, I'm just going with a small little bit of a change in our programme. So, can you continue to tweet, please, if you wouldn't mind, and just to remind you that the presentations will be available afterwards as well. So, our first two speakers are Derek Cribben, who's the National Nurse Lead for the National Clinical Programme for Critical Care, and Etna Hartley, Candidate AMP, Critical Care Outreach in Tala Hospital. And their presentation is Reaching Out in Response, the Evolution of the A&D Response Team. Thanks very much.
How are you? Thank you very much, Aveline, and all the DPIP team for giving us the opportunity to discuss around the evolution of the AMP response system, reaching out in response. I'm going to start the slide with some context and the importance of understanding that the Irish National Early Warning System is a system, and it's not about a score. So it's really important, this major change, because that's allowed us to put in place the right response systems in order to anticipate, recognise, escalate, respond, and evaluate the care of the clinically deteriorating patient. So if we decide to take an action, we have to make sure that that action has had a response. There's no point in doing something and not seeing if it has a response. And a part of the reason that we are advocating the type of AMP role that we are with regards to this response system, and Etna will talk in more detail about the role that they do, is because of a literature review that was carried out with detail around the INUs too. And the findings on escalation or failure to escalate were linked to a number of really important points. So clinical judgment based on clinical experience and confidence was identified as both a facilitator and a barrier to escalation of care. So what we mean by that is that when a staff nurse or staff member had clinical confidence in their own skills and ability and were able to recognise deterioration, it was a facilitator of escalation. And conversely, clinical overconfidence was seen as a barrier to escalation, where study participants overestimated their clinical ability and disregarded the INUs and the score. There was also really interesting literature around the reported fear of reprimand for activating a response system, and fear of looking stupid with colleagues as being significant barriers to escalation. So when there was a positive response from response team members, it encouraged staff to escalate during subsequent events. And these are really important elements to our endorsement of the model that we're going to be discussing. So iNews advocates an anticipatory model of care. It acknowledges the vulnerability of patients at low and sometimes no iNews scores. It involves the earlier recognition of the potential for patient deterioration through the use of clinical judgment, situation awareness, and an appropriate response model. The tiered response model allows for the clinician at the bedside to escalate care regardless of the patient's iNews score. And this is really important. Calls of concern are really important. A number of the speakers talked about them earlier on. So the ICU audit of 2017, it identified, when benchmarked against critical care units in the United Kingdom, that critically ill patients in Ireland were sicker on admission to our intensive care units. They'd shorter lengths of stay, so they're sicker, but they stayed for shorter lengths of time, and they were more likely to be discharged out of hours. So there was more likelihood of there being an unplanned out-of-hours discharge from the intensive care unit. And the subsequent report in 2018 also had more findings which clearly indicated that we needed to do something with regards response, etc., and the development of critical care outreach. So that response system and developing a robust response system was really important. So critically ill patients were being discharged with really high early warning scores, with some units transferring 25% of their critically ill patients to the wards with scores of 6 or above. If a patient develops organ failure in 4 or more organ systems within 24 hours of admission to ICU, it's suggestive of a delayed admission to the intensive care unit. And the national rate in Ireland was 11.5% compared to the UK, which was 9.3%. And one Model 4 hospital had a rate of 16.7%. So 16.7% of all of their admissions to their intensive care unit had organ failure in 4 organs within 24 hours of admission. Delay in admission to the intensive care units for critically ill patients worsens their outcomes once they get into their ICU. And this audit reported that only one unit achieved the HSC target of 50% of admissions within 1 hour of agreement for requirement for admission to ICU. And only 5 of the 18 units audited achieved the HSC target of 80% of patients admitted within 4 hours of a decision to admit. And readmissions to intensive care unit as well were high. You know, they ranged from between 1.2% to 3.1% in Ireland with this report. And one of the really important drivers for us to develop an AMP-led response system was a recommendation within this report indicating that we needed to look at best practice into providing optimal care for high-risk patients outside of critical care, and that it needed to be explored the potential benefits of critical care outreach teams. So the response team that we're advocating for, it's not the outreach model of old, and outreach is a bit of a dirty word in some corners. We call it reach out in some places. So we're recommending structures where care of deteriorating patients is not taken over by an outreach team of Wonder Women and Supermen. There's evidence that these can de-skill our nursing and medical colleagues in the care of deteriorating patients and creates an additional burden of care onto senior critical care colleagues. The structures that have evidence of working well to date in Ireland are an AMP-led supportive educational resource service for ward staff, both nursing and NCHDs, where a mantra of all calls are appropriate, no question is a stupid question, in order to facilitate a supportive full assessment of the patient, which gives educational opportunities in the care of the patient at the bedside. Now, this is really important because every patient assessment is an educational opportunity. We need to be able to teach our people how it is that you care for these deteriorating patients, but we need also that they know that there is a support structure there for them if needs be. And this is key. So when agreement of a care plan is reached with the primary team, patient stays with the primary team, timely follow-up of this care alongside the primary team and ward staff is put in place to gauge its effectiveness. If we do something, we need to see does it work, and that's really important. So this is our system, Rob's from Aileen McCabe. The model supports all aspects of the acutely and critically ill patient pathway, including early identification and management of patient deterioration, timely admission to an intensive care bed when it's required, delivery of effective follow-up for patients post-discharge from the intensive care unit. It is also fundamental in providing educational support to enhance the skills and knowledge of the multidisciplinary ward teams caring for at-risk or deteriorating patients. The 4 overall responsibilities of the registered advanced nurse are to share critical care skills in the general hospital wards, ensuring enhancement of training opportunities complementing the role of the other healthcare providers within that setting. Avert admission to critical care by identifying patients who are at risk of deteriorating, initiating early interventions and supporting care to prevent or minimise deterioration. A collaborative approach in the development of an AMP service ensures that the critical care team has awareness of potential admissions to their unit, and ensuring access to critical care bed happens in a timely manner. And I'm going to go through some of the indicators that this type of service is working really well where it is available. And equally, and I think this is a really kind of missed point with regards to the outreach service, to enable safe discharge from the critical care unit by supporting the continuing recovery from critical illness. Us as critical care practitioners, and we have somebody who's in the ICU for 50, 60, 70 days, you know, they're stable, off they go. But arriving to a ward, we need to get them people prepared for that as well. And initiating, where appropriate, end-of-life conversations with regards to that potential critical care admission. It's important to understand that admission to this service is an adjunct to the primary care, similar to any referral. So it's an admission into a service. And the service is available to all staff in all departments and wards who may find themselves caring for a patient who they may have a concern or at risk, or are requiring complex care or are deteriorating. All patients referred to the service should be followed up until their clinical condition is stable and no further reviews are required. In essence, they get discharged from the service when they no longer meet the admission criteria for entry into it. And in a nurse-led response service, the decision-making has been made possible through the mentoring during the candidate AMP stages by their medical supervisor, which also enables the development of an engaged relationship with our clinical colleagues. And this is why we're advocating that this should be an AMP role, is so that we can build up the confidence with our clinical colleagues with regards to this. The National Council for the Professional Development of Nursing and Midwifery, they outlined that the crucial factor in determining advanced nursing practice is the level of decision-making and responsibility rather than the nature or difficulty of the task. So it's about our ability to communicate. It's about our ability to be able to support people. It's about our ability to be able to educate people around the deteriorating patient. It's great that we can do tasks, it's great that we can do interventions, but it's the communication part of this that is key and why it's a success. Now, evidence to date has been similar across the 3 sites where models like this have been implemented. And what I'm showing you now in this slide is where we've got verified data. So in Tala, there was a decrease of in-hospital cardiac arrest of 50%. And Siobhan Connors there, the top left-hand corner, is one of the really important people with regards to our enablement of the development of this, because without that data, we would have got nowhere with all of this. In Cork University Hospital, and I know Darty spoke about it, but I think it needs to be reiterated, on the medical and surgical wards where a safety huddle with a deteriorating patient service was introduced, the time between cardiac arrests increased from 59 to 183 days, and 46 to 255 days when they did that study. Now that's massive, you know. That's the 6-fold that Dorothy was speaking about, is that 46 to 255 days. In Galway, which is the highest number of AMPs delivering the service and are moving towards a 24/7 service, the evidence has been further demonstrated by a decrease in readmissions to the intensive care units of 75%, and a hospital-wide SMR, standard mortality rate, decrease of 12.6% in a 6-month study carried out in 2018. So these have real impact with regards to patient outcomes. New services are only commencing around the country as well, and the services need to be given time to embed and to grow, you know. So we've got new services happening, but they're not going to be a magic wand that are going to produce those kind of results overnight. So in James's, they're doing this about a year. But they already have clear indications of the impact that this team is having with regards to that KPI when the decision to admit is happening. So those patients where the 50% within an hour, when those people there see that patient, they're getting to the intensive care unit 90% of the time within 1 hour. That's massive, you know. The service in Limerick, again, has only just begun, but they're starting to see clear indication with regards to the support that they're offering to their multidisciplinary teams on the ward. In the Mater Hospital last year, the service reviewed nearly 500 complex discharges from the ICU, providing, again, significant support to the people on the wards. In Beaumont Hospital, data from April 2021 to May 2022 showed that over 1,000 patients were reviewed post-discharge from the ICU. Well, sorry, 51% of those were post-ICU discharge. And St. Vincent's Hospital, and this is a baby service, but they're already starting to see evidence with regards to decrease in readmissions to the ICU. With that data needs to be verified, but they're starting to see that already. There's only 2 of them there. There's Joe and Karen, how are you? So they're starting to see that impact again. But again, these services need to be allowed to start and to grow. You know, 2 people can't deliver the service, but they can start the service, and that's the important thing. In Drogheda Hospital, Gary and Sinead here were incredible with regards to the educational and clinical support that they gave during COVID, along with their respiratory colleagues, to enable the delivery of non-invasive ventilation and the delivery of conscious proning for those patients during COVID as well. There's a proposed clinical governance structure for this AMP-led service as well, and this is really important. And it talks to the deteriorating patient committees that were discussed earlier on. And it's important because what we need is to have an integrated clinical governance arrangement which joins all of the moving parts of nursing governance, medical governance, hospital clinical governance, and hospital clinical directorates governance into one clinical governance structure for the response to those deteriorating acutely ill patients in the acute hospital setting. And this is important because, as Etna is going to discuss now with regards to the service that they do in Tala, it's the only AMP service where you're likely to see any patient under the care of any team. So we need to make sure that what we do is we deliver a service that people become confident in, that has an impact, but also protects us and the patients with regards to those clinical governance structures. Etna, you're up.
Hi, good afternoon. I'm Etna and I'm a candidate AMP in Tala Hospital. I'm just going to discuss the development of the critical care outreach service in Tala, the day in the life, the referral and discharge pathways, and going on establishing the AMP service. So in the history of the critical care outreach in Tala University Hospital, as Derek has mentioned, Siobhan Connors was one of the leading members, but we established in 2010 an MDT, a multidisciplinary team steering group, to develop the emergency response system, and which encompassed the recognised response, education, evaluation and governance. From there, we have, in 2015, we have further developed, to 2021, sorry, we further developed the nursing role into a recruitment of 6 whole-time equivalents as critical care outreach clinical nurse managers to cover a 24/7 service. So the actual 24/7 service was established in the middle of COVID. So we're now finding our feet in a more generalised hospital setting. At present, we have 2 candidate AMPs. We have a further 2 candidate AMPs commencing in September, and all our roles are funded for an AMP progression. So with the iNews new development in 2020, the critical care outreach is now incorporated into the escalation protocol, and I'll talk about that in a few minutes. So what's my day like? My day is busy. So we start with handover from a team members. So whatever critical care outreach team members on the previous shift, we get handover. Events of the shift is highlighted. We are handed over patients that are included on the critical care outreach service at the time, the critical care bed status, and number of ERTs, cardiac arrest calls, or any calls of concern that occur. We then go for a critical care handover, and we identify patients for discharge from the critical care, whether it's our ICU or our PACU or our high dependency unit. We receive referrals from the previous shift that anaesthetics may have seen, or the intensivists may have seen patients in ED that are now on the wards that may be at risk of deteriorating. We also liaise with the consultant intensivist and the SPRs that are covering referrals with any of our patients of concern that may be on our list that we would like reviews on. We need to prioritise our patients, obviously, and so our priority is with patients that need ICU or critical care review, patients that may have deteriorated overnight, and we give feedback and we gain supports from our critical care colleagues. The next, we prioritise patients that have been highlighted to us for early review. So these may be patients that have been sick yesterday and that any treatments or evaluation of treatments mightn't have been as beneficial or as we expected, and we'd see them as a priority too. Next, we would do our routine reviews. So as Derica says, we have complex care patients, which are tracheostomy, laryngectomy patients. So we routinely review those, and or patients that are near discharge from the service. So these may be patients that have been critically unwell or they have deteriorated, but the management that has been implemented at the time, we're evaluating and they're improving. And we're autonomous in our discharge from the critical care outreach service. And they may be referred again, but I'll talk about that again. So everything goes great until you have an ERT or a cardiac arrest call, and on roughly we have 500 referrals in 5 months with greater than 2,000 reviews, and of that 50 patients have been admitted to ICU. I'm not going to go through this, it's a really busy slide, but it's just basically that we get referrals from everywhere. So from the deteriorating patient, call of concern, track and trigger, iNews, from our escalation protocol, our review of higher level patients that are discharged from ICU or PACU or HDU, and our complex care patients. And they're discharged off our service once we deem that they're fit or they don't meet the criteria. This is Tala's development of the new iNews, and we are incorporated from 4 to 6 with immediate review for 7, or it can be an emergency response team call, which is an emergency call. Likewise, we have 2 boxes at the end, incorporated to see where patients have been already at ERT and they have now, for out of hours, doctors. This is all patients are reviewed from critical care. It's a traffic light system, but we're actually reviewing all patients discharged from critical care. So as an AMP, we complete full episodes of care, prescribe and refer for radiology, invasive monitoring, establishing treatments, evaluating treatments, audit research, education and training, and keeping our practices up to date. So this is us, this is Tala. I think we were a friendly bunch. There's 1 or 2 that are missing, they're a bit camera shy. But it's just to say that it's the cornerstone of our role is to be supportive. We don't take over care of the patient. We are there to support. There's no call. If you're in doubt, you put the call out. If you want to know answers to a question, if you're willing to listen, of course, we'll help. And yeah, thank you very much. Thank you.
Thanks very much. That was really good and wonderful to see all the work that's happening in Tala, but also happening around the country. And I suppose more importantly, the resources that are being put in there as well. So we'll just move on now. Our next speaker, I'm delighted to welcome you back to Ireland again, Chris, is Mr. Chris Hancock. He's the clinical advisor in Welsh Government and was the national lead for Acute Deterioration Programme Wales. I'm going to pronounce this wrong now, but you can fix it afterwards. Simrose at Wales. So your presentation is a systems approach to recognising and responding to the deteriorating patient, and just the learning from your Central Wales.
Thanks very much, Maria. And what a real pleasure it is to be returning to this wonderful building. Approximately 9 years, I think, since Evelyn initially invited me when I was invited to talk about Wales's introduction of news, as I think our two countries were really sort of at a similar level in its introduction at the time. I've had the pleasure of returning to Republic of Ireland a couple of times since. I've been to see Dorothy in Cork a few years ago and most recently in Mayo as well. So I've always been very welcomed. For full disclosure, so I was the manager for, or the lead for the acute deterioration program in Wales for 10 years. I had the privilege of doing that. The program was in the process of transition to another format as COVID struck. So as a result, and I was also seconded over to Welsh Government as part of the COVID effort. And as a result, at the moment, we do not have a deteriorating patient program within Wales. So what I'm hoping to give you this morning, or sorry, this afternoon, is a bit of a review, an overview of my reflections, I guess, after 10 years of running the program, and hope that that's helpful for you. So as I mentioned, full disclosure earlier, I'm also a fellow of the Scottish Patient Safety Program. I think I'm right in saying I'm the only Welsh fellow, and Evelyn and I were in cohort 7. 007, nobody does it better, as we like to call ourselves. And I'm also the Welsh representative on the executive board of the National Outreach Forum. So in the UK, that's the outreach body that represents, if you like, the outreach. So my background is in critical care nursing, and most recently, clinically, I was a practice educator, and I would have told you, well, at the time that I was doing that job, that in order to improve, what we need to do is to improve the person. We need to educate the person, we need to train the person, we need to monitor the person perhaps, and so on. And I would have advocated that education was absolutely essential. Once I started doing quality improvement work, that attitude very quickly changed, and I very quickly appreciated that education is necessary, but it is not sufficient, as the quote goes. And these two guys that you see there, they're very old quotes now. Deming's, I think, been dead for quite some time, but I think nevertheless they encapsulate a lot of my initial learning when I started to work in quality improvement, and I'm sure it's the same for yourself. It's about the system. It's not bad people, as Don Berwick says, that harm and kill our patients. It's bad systems. And meaning well, as Deming points out, is not enough. If you put a good person in a bad system, then the bad system wins every time. So fundamentally, I'm very pleased to be able to talk to you about the systems approach, because I very quickly discovered that if you want to change healthcare, you need to address the whole system and enable people to change that whole healthcare system. So I started my training a long time ago, 1987. When I started my training, cardiac arrests almost seemed to be happening at random. Well, the appreciation was that a cardiac arrest would happen maybe anywhere within a hospital, any time of day. You could really not predict it. But nevertheless, constantly through that time, reliably there has been data and studies showing that you can predict cardiac arrest, you can predict deterioration, and really we probably all knew it all the time, but we had no means of addressing it. The earliest work on this dates back probably to the 80s and concentrates on what De Vita et al. Described in the first consensus statement on rapid response systems as the afferent and the efferent limbs of the rapid response system. And that is essentially somebody notices that a patient's going off, and then somebody responds to them noticing. That very sort of dual approach, if you like, was prevalent throughout the earlier period. In fact, actually, it was less about the recognition and more about the cavalry responding and coming in very often at the last moment. And that's probably why the MERIT study, when the findings of the MERIT study, that a MET team on its own was not sufficient in order to change your outcomes for your patients. That's probably why, because we were only considering the one aspect of it. Moving forward, for me, I think this was quite an important report from NCPOD, a UK organisation, National Confidential Inquiry into Patient Outcome and Death, 2012. And in this examination of cardiac arrests, as we know, a lot of them as a result of long-term deterioration rather than cardiac issues, they identified that actually there were far more steps than just a simple call and response. They were looking at escalation within there and escalation to the correct person, so the correct person needs to respond. And the National Outreach Forum, I think, you know, very quick onto this with their PREPARE acronym, in that they showed that actually this system of acute deterioration is multifaceted, and we need to address all of that system if we're to have a hope of improving outcomes for our patients. So I'd like to think that that's actually been my approach, or was my approach, when I managed the RAILS program, Rapid Response to Acute Illness, which was the Acute Deterioration program, in that we looked at it in the round as a system and how do you improve the system. So we started as part of the 1,000 Lives campaign back in 2008, but we really only took off once we had the commission from Welsh Government to introduce the National Early Warning Score, which we started to do in 2011. We established a steering group for the work, which persisted all the way through the 10 years, and I think was probably one of the most important factors in its success. And as you can see, I won't go through all of them, just to give you a little bit of an idea about Wales, population 3.1 million. It's a devolved healthcare economy within the UK. We have probably around 18 acute hospitals, but more than 50 acute community mental health facilities, some of them in very rural areas. So I think there's probably a similarity across the board with some of that. So throughout the period of the RAILS programme, we, usually on the Commission of Welsh Government, introduced various aspects like news, most recently community news, where we introduced it outside of the hospital as well. And we also did a lot of work on the universal definition of sepsis, escalation and treatment of sepsis as well across the whole of Wales. Plus, we also responded to things like News 2 being published as and so on. But for me, it was actually the spread of news that did it at the start. So the dots represent where news has been implemented. So by 2013, we'd implemented news in all of the acute hospitals in Wales. By 2015, in all of the acute community mental health hospitals in Wales as well, which meant that news was embedded within all of the observation charts, but also each of the organisations had to have an escalation plan involving news at the 3 trigger points that we had and continue to use of 3, 6 and 9. 3 is a threat, 6 is sick, 9 is now. And we've stuck with those throughout. So actually the spread of news started the process of changing the whole system, it didn't just introduce an early warning score. Now, you know, this is just data associated with a particular timeline, so there's no sort of peer review of this data. But what we noticed, and we think that we actually did see, was that at the same time as we started to introduce news, the ICD-10 codes for 2 sepsis codes, they carried on increasing in terms of we were recognizing more sepsis, but we started to see a reduction in the mortality associated with those codes as well. There's nothing particularly scientific in that study, but we're convinced that something happened once we started to act as a whole country, introducing news. So as a result of all of this improvement, and partly as a result of an ombudsman's report, so the Welsh Ombudsman's report, which mentioned acute deterioration, Welsh Government commissioned myself and my team to organise a peer review of acute deterioration services around Wales, and I just wanted to share a few of the reflections from that. Don't work for an inspectorate. We had no sort of mandate to insist that any particular intervention needed to be introduced. So we approached it, we agreed to do it, but we approached it in almost like a quality improvement manner, if you like. We agreed, but it would be about enabling the organisation to own their particular issues and to support them to improve. We don't have a particular set of standards around acute deterioration. So we had to look to related standards like our patient safety alerts and some of the publications that we had. But what we did with that was then we put together a multiple item self-assessment checklist, which we then sent out prior to any sort of peer review, sent out to all of the health boards. And you can Google the peer review and you can actually find the document online, so the self-assessment's in there. So the structure of the peer review itself, and of the self-assessment, we borrowed heavily from Don Abedian, so structure, process equals outcomes, so that's in there. But we felt it important to add a bit of governance on there as well, and we've heard about that today, and I'll talk a little bit more about that, and then talk about the training and education side of things as well. So we used that as the structure for the self-assessment, but also for the peer review when it took place. So initially, we asked each of the health boards to fill in the self-assessment, which they all did almost immediately. But the peer review took two years to complete, because then what we would do is we would visit the relevant health board, each of the hospitals. We would discuss what they'd submitted as part of the peer review, what they'd hoped to improve, what their data showed, and so on. And then we actually walked the wards. Then we went out and actually spoke to the staff and see what we've been told, is that actually true? Is that what's actually being implemented? It was a great experience for myself, my team, and the peers who came along with us on those visits as well. But what was really interesting was how doing this, because it took 2 years, by the time we got to the end of the 2 years, a lot of the later health boards had actually implemented a lot of the stuff that we'd suggested the earlier health boards do. So it acted to drive improvement, the whole process. Because it wasn't challenging, because the end result was an action plan that the health board was expected to put into place, rather than a report from ourselves that would be critical of them, they saw that as an opportunity to improve. So some of the findings and the recommendations we've sort of themed, because they were sort of common to all of them. So I just want to talk through, in terms of some of those criteria, what those are. So under governance, one of the universal things, and it's been heavily alluded to today, was having people in control of the system, or people who were high enough within the organization that they actually had a bit of clout, so that they could, it wasn't just a couple of nurses who were trying to change things by introducing a sepsis algorithm on 1 or 2 wards, that you had an overarching, each hospital had an overarching acute deterioration board, if you like, or group. And very often what happened was that it merged with the resuscitation committee within each of the health boards. Just having resuscitation on its own now seems like perhaps a bit of an antiquated concept. So a lot of them formed what's called radar groups, and I'm afraid I've forgotten what the acronym stands for, but they were essentially acute deterioration and resuscitation. The second thing was, in all of the health boards where they'd actually made strides, they had a very determined doer, if you like, the person who actually went out there and did the stuff. Very often it was a nurse. Well, actually, it was always a nurse. But you need somebody who has that as their role description, not somebody who does it in addition to doing something else. So in addition to being the resuscitation officer, I also roll out, news and acute deterioration. So that was universal. Something that wasn't really included within the recommendations, though, and which I think is absolutely essential to point out, and Dorothy has touched on this earlier, is the literature on high reliability organizations. And one of the criteria that Wyke and Sutcliffe in the book here set out is sensitivity to operations. And that means that the people who are at the top of the organization understand the work in the same terms that the people who are actually doing the work understand it. And in order to get that, you need a common language. Well, it's one of the things that you need is a common language. So, for example, we used, from a very early date, the Sepsis 6 bundle as the sort of the standard or the optimum response. Now, over the years, the evidence supporting each of the elements of the Sepsis 6 bundle has become weaker and weaker, to the point where probably some of them, there isn't much evidence supporting them. But nevertheless, the Sepsis 6 as a concept is well understood. So by using compliance with the Sepsis 6 bundle within 1 hour, or a decision not to treat as sepsis, as a measure, we were able to use the same definition for the ward, which would then be considered at the board level within the organizations, And then for several years, we also had reporting to Welsh Government using the same definition of sepsis 6 on compliance with that within 1 hour. So it was used as both a quality improvement tool, but also a quality measure or quality assurance measure as well. And of course, news performs exactly the same function. News protects, news detects, and most importantly, from my perspective, news connects. You know, I knew that it had become embedded when it became a verb. You know, when the patient starts newsing, or they're newsing at 8, or they're newsing at 7, and everybody was talking about that. And now we have a whole healthcare system that very many of them, people in it, don't know anything other than news. It's become embedded within that. As structures, again, previous speakers have talked about the necessity of a 24/7 system. Having a system that's sort of quite patchy and you never quite know when somebody's on or off in terms of the response team is possibly even worse than, you know, not having a 24/7 system. So we couldn't, as I've said before, specify that you have to have a critical care outreach team because that wasn't the function of the team that I worked with. But what we can say is that you need to have a 24/7 rapid response system that contains the features of a critical care outreach or acute intervention or a rapid response team. And we had the task and finish group report, which we could actually base what those criteria were on as well. Ensure the whole hospital daily huddles and ward shift handover explicitly feature information on patients. As we saw some really good examples of huddles, particularly whole hospital huddles, but a lot of the time it's focused on flows. So we had to try and prompt people to introduce elements of acuity within their huddles as well. So alongside structures, I'd say if you can have anything, have a critical care outreach team because, you know, my term for them is they are the patient safety engine of the hospital. You know, the amount of ability to cover all of the areas within a hospital, their intelligence about what's going on across the whole hospital. And when we introduced all of the elements within the acute deterioration program, they acted, you know, as they were change agents, educators, researchers, data collectors, patient advocates, of course, as well as doing the day job, you know, the liaison between critical care and the wards as well. And I'm pleased to say that the Welsh Outreach Forum, WARF, is actually going from strength to strength, despite us not actually having any sort of anywhere for it to sit at the moment. But definitely, if you can do nothing else, get a critical care outreach team. Along with the processes, concentrated a lot on standard operating procedures and care bundles and so on. And the reason for that is, as we all know, going back to McGlynn et al., 2003, you know, the reliability of, well, the technical reliability of healthcare in the American system is something like 45%, I think was the original evidence. Mitch Levy, who started the director of the Surviving Sepsis campaign, says, you know, the difference between perception and practice, what we think we do versus what we actually do. And also, more recently, this idea of safety too, about how important it is to make sure things happen right more frequently, as well as to investigate what goes wrong. All of these things, I believe that simple things like care bundles and standard operating procedures, as long as you have a simple means of measuring compliance, can actually give you a lot of that assurance. And more importantly, probably, give people permission to act when they're not quite sure what they're supposed to do. If you've got a care bundle for a response, then the person knows that they're able to do that. Also gives you process reliability, assurance of quality of care, and so on. That's from 2010. That's the original driver diagram for the Rails program. Also, a fair bit on outcomes, and what I talk about is the dark matter of harm. And the idea of this is that we're told that dark matter, you know, astronomically takes up a larger part of the universe, most of the weight of the universe apparently, but actually nobody's ever seen it, we can't find it. And similarly, what's causing a lot of harm, very often isn't measured because it's too difficult to be measured. We just don't see it because actually very often we assume that it's just a normal part of how a hospital or a healthcare system functions. So, you know, some of the examples on that are particularly looking at chest and urinary tract infections, specifically sepsis, AKI, and the amount of harm that those cause, rather than the ones that are just easier to measure. And I won't speak at length on this, but I would direct you towards this paper as well. So Chris Suby is the lead author. I'm one of the authors on it. And this came up with a set of metrics for evaluation of rapid response systems as well. So worth checking out. Measure the right thing. Training and education, won't dwell too much on, other than when we worked with aviation, they were absolutely horrified that we didn't train as teams, that we would send a group of nurses would go off and do one part of training, group of doctors go off and do another part of training, and very often our levels of simulation were not very good either. So a lot of our improvements were around that. So what we didn't cover, because it was about hospitals, was the obvious fact, and one which COVID has really driven home as well, that all of this system is far larger than just the hospital. And one of the things that we did, or one of the last chief nursing officer did, was ask myself and my team to introduce news in all of the district nursing and community resource teams across Wales. And that entailed introducing it in quite a few care homes as well, as they were very large, almost healthcare providers within there as well. And that map there sort of demonstrates that of the 160-ish district nurse teams, we managed to get about 90% of them working on this just prior to COVID. But once COVID had hit, they all had to take it up because it was obviously so useful during COVID with the addition of a SATS probe as well in being able to identify in community people who have COVID. So community and work towards that, I would hope that we would be doing far more on. And obviously, a vital part of this whole system, which I haven't touched on at all, is the patient or the person within the system there as well. And some of you may be aware of Chris Suby, my colleague from Wales, and the work that he does on patient-powered safety. And I was very struck by Alison Phillips, who had a really, really rough time with sepsis. She's an ex-patient, but her quote, as you see there, "Surely we all have the right to save our own lives, even in hospital." So putting the power back into patients' hands and making them part of the system. A bit of work that's taken off a little more recently is the UK group on worry and concern, and I'm a part of that group. And there's two elements to it really. One of them is enabling patients and their carers to be part of that escalation system. And there's a lot of work, if you're interested in that thing, done by Mandy O'Dell in Reading, which is under the name of Call for Concern, where what they've done is they've given the outreach number, phone number, to patients and their relatives, and they've given them permission to phone if they have concerns about their relative care deteriorating. The second is more about how do we get patients and their relatives and their opinions and their valid opinions on the health of their loved one into the notes. And that's work that's going forward at the moment. And I'm pleased to say this is a set of metrics that we're pretty close to adopting within the Welsh Outreach Forum. And as you'll see on there, the number of referrals to critical care outreach by patients or carers is one of the metrics that we're proposing that we adopt. Not to say that we've got anything other than pilots of Call for Concern going in Wales at the moment, but that's certainly something that it seems to be the way that we're moving. So in conclusion then, I'd say on my reflections really then, acute deterioration exists within a complex system, and you have to, if you want to improve it, you need to work on improving the system. Education is necessary, but not sufficient. Using a peer review of acute deterioration systems, and I wouldn't have thought it at the time, but actually works as a driver for improvement, and something that's a process that I would really recommend. Sensitivity to operations. Ensure that you have one language throughout the system so that everybody at all hierarchies within the system are actually speaking about the same thing. Everybody has the same understanding of the work as done, if you like. Critical care outreach team, it's my opinion, but I would say the patient safety engine of the hospital. And care bundles, standard operating procedures, give permission to act, drive process reliability, improve the quality of care. Think about the dark matter of harm, what's actually causing the harm, not just what's easy to measure. Training teams for real-world events. The system is far larger than the hospital, so we really have to work on, particularly in these times, preventing people even needing to come to the hospitals because we're running out of the capacity, aren't we? And then finally, but possibly the most important, make safety patient-powered. Thank you very much for your time.
That was a wonderful presentation. Thanks very much. And I just really love the patient safety power. I think that's really something, and it's really good to see such patient engagement as well. So just moving on, and thanks for keeping on time. I saw you keeping an eye on the clock as well, so saved me a job. So next we have Dr. Nigel Salter, consultant in emergency medicine, St. Vincent's University Hospital, and lecturer in the RCSI. And we have Dr. Conor White, specialist registrar in palliative medicine, St. Francis Hospice, Blanchardstown, and chair of Respect Advanced Care Planning Working Group at St. Vincent's University Hospital. Thanks very
much. Good afternoon. Thank you, everybody. Nice to see lots of familiar faces. So why are an emergency medicine doctor and a palliative care doctor standing in front of you? It sounds like the start of a really bad joke. As my introduction says, I work as an emergency medicine consultant at St. Vincent's Hospital. In fact, on the 1st of July is my 10th anniversary as a consultant. I believe that I'm entitled, oh, thank you. Well, I understand that I get a complimentary psychological evaluation from the HSC after that, but I'm talking to you as someone who does lots of resuscitation. I do it nearly every day. I think it's really important that we do it well, and I teach resuscitation. I've been involved in ACLS training for over 15 years now. I used to have hair when I started doing it. In terms of, where's my mouse? There it is, sorry, thank you. So in terms of resuscitation, some of you may recognize this image from last autumn. And when a Swedish player, Christian Eriksen, he collapsed during one of the opening games of the Euros 2021 tournament. And he had resuscitation performed in front of a live television audience, not the first time it's happened. And these rather moving scenes as his team made a human shield around him. And what struck me afterwards was, we were going through a process trying to advocate for a cardiac arrest audit at the time. And the media response, the social media response in particular, where we saw people's outpouring of emotion in relation to seeing these scenes, and even doctors and nurses on things like Twitter talking about how emotional they felt at seeing this happen. Even though they were involved with resuscitation as part of their work, this was different. This was a young person suddenly collapsing and dying, and it illustrated the importance of what we're trying to do. Resuscitation is about trying to reverse the reversible, and that's what it's about, and that's what we try to teach. And what we've seen today are so many important things in terms of trying to drive that. I guess the reason I show that is because this is an important issue for our patients, for their relatives, and for us as staff. We should be doing it right. And at the moment, as we mentioned earlier, we don't have data in Ireland. We have some hype data. It really just tells us about possible instances of cardiac arrest. I know from my own organisation, it grossly underestimates it. It tells us nothing about the quality of resuscitation that we're doing. It tells us nothing about our ability to escalate and respond to it. And I know I'm speaking to an audience who knows this. Now, in the last 2 years, I've had the pleasure of being involved with NOCA and DPIP on this feasibility study. And we've looked at that in terms of how we can approach metrics for the deteriorating patient. And I think on this slide, this is one of the things I really took away from this project, the deteriorating patient journey. And you can see at the bottom of it, we've got cardiac arrest. That's where we don't want people to get to. We were saying earlier, we know from the NCPOD report from the UK, at least 40% of cardiac arrests are estimated to be avoidable. And that's what we're trying to do with iNews. And you can see with our response and escalation systems that we have a process now where we can start to try and impact that. And it's really important we start to measure and show that it's having an impact on our systems here in Ireland. What we want to talk to you today in our little section is the other group of patients who aren't for escalation and for whom we need to start thinking about ceilings of care. And we alluded to that earlier on. And we talked about respect. And one of the experiences that they've had in the UK, where a national cardiac arrest audit, this is one of the things when I travel, particularly to the UK or Scotland or Wales, they start using abbreviations that I just don't understand, that belong to the NHS. And we perhaps are guilty of it today when we use terms like HSE, NOCA, NCCA, NCAA. But unfortunately, the National Cardiac Arrest Audit is what we're talking about here with NCA. And what they have found is that by measuring this data alone in the UK, the realised benefits are they are reducing their rate of cardiac arrest by 6.4%. And they're seeing an increased hospital survival of 5% per annum for these patients. And the other thing that they've done is that they've introduced a strategy for ceilings of care. And now I'm going to hand you over to Conor to talk about that in more detail.
Again, it's been echoed earlier on, it's great to be in a room, physical attendance, and people to share background. I'm all about breaking down silos. I'm a palliative care doctor. There's probably not many of you in the audience. I've also got a grounding in general practice and acute medicine. So I was a GP in the UK, and I've worked in acute medicine in Northern Ireland and England as well. So I'm going to speak to you a wee bit today about advanced care planning. Pardon me. Thank you. A little bit about the audits we've done in Vincent's, our background in our national legislation and policy, talk about respect and how we're going to look at respect at Vincent's and beyond. It's after lunch, it's a late slot. This is the take-home message. In fact, we need improved advanced care planning across Irish healthcare, across all settings. Not all patients actually want escalation of care, and not all are appropriate for further escalation beyond what their current ceiling of care is. Improvements in advanced care planning support clinicians to make patient-centred, appropriate care decisions under emergency circumstances. And using respect, which is an established improved advanced care planning mechanism, we can impact patient safety fundamentally and patient outcomes. There's also a significant benefit here towards staff outcomes. All of you, I imagine, clinicians certainly will have been at the pointy end of a 4 o'clock in the morning resuscitation of a deterioration patient that you don't know, that you know aren't going to survive the CPR episode. You know that walking into the room, and there's not a piece of paper that absolves you from doing it, so you start, and you call it 10 minutes later. This is fundamentally traumatizing. It's traumatizing for the patient, it's undignified for us, we hurt. They'd be better off having their 6 relatives there rather than their 6 CPR providers. How can we change this? We all know it's the truth. So fundamentally, advanced care planning helps an individual to identify and document their future healthcare preferences for when they can no longer express those. Obviously, if you've got a deteriorating patient who can still speak to you, you ask them their preferences at the time. We know from evidence that it reduces but does not prevent all inappropriate or excessively invasive treatment, but it does help. We've had long recognition between multiple episodes of the multiple iterations of the National Consent Policy about improvements in advanced care planning. There's a whole chapter on it, part 4, do not attempt resuscitation. And we know from the Staunch Care report that there's a need for improvements in advanced care planning to improve patient flow and patient outcomes across all healthcare settings. I know this is predominantly an acute hospital group, but this is a significant community issue, as Chris alluded to in Wales. When COVID happened, one of my neighbours walked to me outside my house. I'm a doctor, so all he knew. He said, if an ambulance comes to me outside my house, Conor, I don't want CPR. He didn't know I'm a palliative care doc. This was a on-the-road conversation during COVID. That's how live this is as an issue. So we're all resuscitation officers, patient safety officers. We know how important this piece is. This was a coffee shop conversation. Actually, it wasn't because they were all shut. I'm going to talk to you a bit about our stats at Vincent's. We suspect that they're echoed around the country. Mrs. Honourals has been great at collating data over several years, despite there not actually being a national in-hospital cardiac arrest audit. Thanks, Nigel. But it was great to have the data. Hospitals in Ireland are a place of provision of end-of-life care. So 40% of people across Ireland die in hospital. There were 33,000 deaths last year in Ireland, as per CSO data released last week. By 2050, we'll have about 54,000 deaths. In Vincent's, with north of 1,600 DNA CPR record forms completed. I'll show you a copy of that in a minute. You'll recognize it as very similar to your own, I suspect. And of our CPR episodes, only 8% of people survive to 30 days or hospital discharge. Again, you've probably got similar if you haven't looked at your data. This isn't much better than out-of-hospital results. Either there's a piece in failing to recognize deteriorating patients, or there's a patient selection problem. In terms of these people were never going to survive. And that's assuming that the education and training piece in terms of provision of BLS and ACLS is appropriate. You will recognize this, I suspect, from your own hospitals, because no hospital I'm aware of, beyond maybe the Midlands, has a treatment escalation plan. So this is a bold DNA CPR decision record form. For CPR, for not, have we talked with the patient about this? Do their family know? Signed by the registrar level or above and countersigned by a consultant physician or a surgeon. When I came to Vincent's, I picked up the phone to Suzanne, our resuscitation training officer. I started 2 months after peak first wave COVID. I said, how are we doing in CPR? And this is how our conversation started. So I ordered the forms from April 2019 versus April 2020 and looked at what our outcomes were. So we had significantly more CPR forms completed in first wave COVID, funnily enough. 60% of these forms are completed outside working hours. I suggest that's probably a reactive rather than a proactive decision-making process, that these are likely completed by clinicians unfamiliar with the patient. 80% of these forms are completed by NCHDs and documented consultant involvement only in about a quarter of them. I suspect these are similar in your hospitals as well, having worked in multiple hospitals across Ireland as an NCHD. A third of our forms had no discussion documented with patients or next of kin. That's obviously a concern. And only 60% of these were recorded in the clinical record, so the paper record beyond the form, despite internal policy. And again, I suspect this is replicated across the country. So we have an issue. There was a significant case in 2014 in England where a lady called Tracy took a case against Cambridge University Hospital Trust, and the UK Court of Appeal found that decisions about DNA CPR record actually involve a person's human rights under the European Human Rights Convention. This is a significant problem for an organisation if it came to court, let alone the individual themselves. So where we stand in terms of policy, the implementation of the Decision Support Service supporting the Assisted Decision-Making Capacity Act is happening this summer. You'll all have heard about it. This puts advanced care planning and directives on a legal footing. The Staunch Care Report, again, discussion about patient-centred decision supporting care across healthcare settings, National Consent Policy 2022 and iterations before, and the own HSE's guidance regarding DNAR planning during the COVID pandemic referenced that Tracy case, the European Convention on Human Rights part. National clinical programs, so older patients, chronic disease management and provision across pathways. This is really relevant. As a working group, we looked around the world basically at different options in terms of advanced care planning. We looked at, but lots of countries effectively come from a government down, whereas Respect was developed from the ground up. Over 100 relevant organisations took part in the kind of effectively modified Delphi process to develop this, and it's now under the auspices of the Resuscitation Council UK. I'm a palliative care doctor. I don't shy away from hard conversations, but I find it really hard to walk into a room and say to somebody, you're not for CPR. I just don't do that. It's impossible. How can I? It's a lot easier for me to walk into a room and say, Jimmy, how are you? What's your understanding about where you are? Do you realise that you would not survive CPR? I can do that piece, but actually giving you intravenous antibiotics would give you a worthy chance at survival. And what we're talking about here is realistic medicine. It's not aspirational medicine, it's realistic medicine. I think a lot of this ends up being education and training as well as policy, as Chris alluded to. But fundamentally, I don't know that our clinicians know where they stand in terms of identifying a deteriorating patient or the dying patient and how to manage that piece. Conveniently, Northern Ireland is bringing in Respect as part of their Northern Ireland Department of Health advanced care planning policy for adults. The potential here for Respect to inform an all-island cross-border advanced care planning piece is very much there. This is the way we should be going, I suggest. The form Gregor pulled up a copy earlier on. Effectively, it's a patient understanding piece. What matters to me most? How do you translate that, what matters to me most piece into a clinical recommendation piece? It's fine to write in the form escalation to ICU, because that might be appropriate. What Resuscitation Council UK have found it initially for the first 6 months, it tends to be these forms are completed for people who are DNA CPR initially. But by 18 months, up to 40% of people are still for cardiopulmonary resuscitation, because clinicians have become used to having these conversations and patients are now accustomed to having these conversations. Within this, there's an aspect of a capacity assessment. Resuscitation Council UK have given us permission to amend this form for an Irish context. They're very, very supportive of us bringing this on board. Where we are in terms of instance at the moment is we have developed a business case for a full-time, dedicated Respect/advanced care planning clinical lead. Within the UK, this is a Band 7 nurse, typically Band 7 role, so that's equivalent about a CNM3 here, and that's within a hospital culture accustomed to using Respect as a policy. Resuscitation Council UK have developed training resources, so it's effectively tiered, 3 tiers. One is that everybody within an organisation recognise what a Respect form is. 2 is that the frontline person will actually be able to interpret the information. And the 3rd is for the clinicians who will be leading these conversations. This is not about a form. This is about training people to have conversations and empowering patients to make decisions about their healthcare. If it turns into a completion of a form only, a bit like our DNA CPR forms, it's not going to work. So this is an education, hearts and minds piece. Obviously, there's a significant workflow piece in terms of NCHDs. We turn over twice a year in Ireland, so it is an ongoing piece there. However, our nursing cohort is relatively stable. It was. But there is a piece there. So it is how we manage that. And a lot of the work is actually going towards an education and training and supporting people to empower themselves as clinicians and staff about having these discussions. I would love that this is going to switch over from DNA CPR to a Respect policy in, really, it's going to be the start of next year. We looked initially at doing an award-based piece and rolling out at small cohorts. However, the reality of cohorting patients, or either from a COVID point of view or a CPE, it meant that people were actually transitioning within the hospital, and felt that the risk to patient care at that interface was too high to actually just introduce it on a perfect. on a ward level only piece. One of the benefits of this, speaking about interfaces, is that this is a standardized form across interfaces. So as a general practitioner, this can be sent to me as an electronic with my electronic transfer from the NCHD, and I can understand this form. I can amend it in community. It is a patient-held document. There's no sense of hiding this information from a patient. It is their information. Where I worked in 2010 in England as a GP on the South Coast, we had something like this. The patients kept it in their fridge. The ambulance crew knew to look for it in the fridge. This is a long time ago. So there's a way of doing this. It isn't foolproof. It's better than what we got. One of the bits that really bugged me and why I started in acute hospitals is because in community, I would have people at end of life under a community palliative care team on a syringe driver for symptom control. Their family would panic. Jimmy's breathless. An ambulance crew would come. There's not a piece of paper. Jimmy gets CPR with a pump. This is the trauma of that as a palliative care doc, let alone a family member saying, actually, no, it's not for that. We need to absolve paramedics, pre-hospital people from doing this. The way things happen is an acute hospital takes this on board and it trickles down. It's the same with anticoagulation. It's the same with all sorts. Stuff happens in acute hospitals and changes across the board. Similarly for nursing home patients. Like, where is this form? This is a recognizable form. Any ambulance, I've spoken with the National Ambulance Service and Dublin Fire Brigade, they're on board. I have never met anybody along the line who says this is a bad idea. They said it's a really tricky concept, and really, I'm with a really willing team to start sorting this out. So effectively, from little seeds at Vincent's, I'm hoping, recently we got approved from Ireland's Hospital Board, Ireland's Hospital Group, basically to stretch this across all of Ireland East. That's news to you, maybe some of you. But that's very recent. So the agreement is that Vincent's will be a pilot site potentially for this to stretch across Ireland East. So we're talking north of 1 million people. This is, I'm happy to be doing this over the next 5 years. And to be invited here by HSE and Deteriorating Patient is really important. Gregor's been speaking here about silo developments of electronic healthcare records, for example, in Scotland. We need to be doing this centrally. A little bit of a personal boast here. So I'm starting a 2-year MD research project in this in July for my sins. So that's basically on the back of this. What I want to do is a mixed methods evaluation of it. Ultimately, I want to teach clinicians, learn, I suppose, from our implementation here. I want to learn how this works for clinicians and policymakers. There is a need for this. And finally, for those who have fallen asleep, the take-home messages here are for, effectively, there's a recognised need for improvements in advanced care planning across all the Irish healthcare settings, not just acute hospitals. Not all patients benefit. We've all heard that earlier on today, and we all know it. Advanced care planning supports us as clinicians to provide improvements in care and best patient-centred care. And using a respect, we've got a decent advanced care planning mechanism. So thanks for your time, guys.
Wow, that was emotional. Thought the first slide was emotional, but I think we can also relate to this in every way, personally, professionally. I mean, I'm out of the clinical setting now for over 22 years, but I can still remember being in CCU and saying, did we do everything we could do? But I also remember being in the wards and saying, look, could we have the respect model, you know? It's just, and you've just done so well, and it's such a wonderful thing to see, and just thank you very much for that. It was lovely, thank you. And very professional as well. So next up we have clinical governance of the deteriorating patient, a hospital approach, and we have Dr. Catherine Wall, Director of Quality and Patient Safety in Tallaght University Hospital. So thank you. Just move that water out of your way.
So good afternoon, everybody. Usually I'm looking for the box to stand on here because I'm very, very short. I'm going to start with 3 disclaimers. First of all, I'm very sorry that I kicked Nigel off the stage. Secondly, it's a really bad slot to be the last speaker because many of the speakers have already used my slides, so thank you very much. And thirdly, as we were talking about anniversaries, today is the 16th anniversary of me being a consultant, but more importantly, it's my 25th wedding anniversary. And the reason that I mention it is that as a healthcare professional, I think to be married for 25 years is a miracle. Okay, so So what I actually like to do when I speak to audiences is I like to ground everything I talk about in a patient's story, for the simple reason that everything we do starts and finishes with a patient. And as a nation, we are natural storytellers. I'm going to follow that with a learning and actions journey. And using that journey, I'm going to show you how we take an approach to the governance of the deteriorating patient in Tallaght Hospital, and then suggest to you very politely how we might use this to take a more national approach. And I will be plugging some of the slides around national cardiac arrest audits, so be prepared. So I'm going to tell you Mark's story, and there's a reason that I'm sharing the story with you. Now, normally I move around a lot, so I wish I was mic'd up because I find it very difficult to stand behind the podium. I met Mark's family on the first day that I took up my role as Director of Quality and Safety. It's fair to say I was pretty wet behind the ears, and it was the first time I'd met a family in this role. But there was a particular reason that I wanted to meet this family. And the reason was the letter that they wrote to patient advocacy outlining the experience of Mark's care. And there were a couple of things that resonated with me. And the two things that struck me were, first of all, that this person, Mark, did not have a good outcome. But the second thing that struck me was when they described in their letter how they had identified evidence that he was deteriorating and how they had pleaded with clinicians to react, to respond, to react to their concerns. And that's really a key message for me. So this is Mark's story. So he's a 70-year-old man with a fairly complex medical history, but nothing that would surprise us in an acute hospital setting. A chronic hematologic malignancy on immunosuppression, a long history of lung disease with repeated hospitalizations for pneumonia, cardiac disease, chronic kidney disease, but a self-described excellent quality of life, fully independent. So he was admitted through our emergency department with shortness of breath. Within 5 hours of arriving in our emergency department, he was on Airvo in the high dependency unit. So on this occasion, we had recognized that he was very ill and we had escalated appropriately. He was discharged to a general ward the following night. And note already a cue for alarm here, this issue that we have with shortage of beds, so we moved people out in the middle of the night. He remained on Airvo with an EWS of 3 and was described as clinically stable. His primary team reviewed him following the weekend, and again, they noted that he was stable. He was on oral antibiotics. They continued to wean his Airvo, and his EWS was 3. So over the next 40 hours, we entered an extended holiday period within the hospital. The nursing staff documentation clearly states that Mark becomes increasingly agitated. He can't tolerate his Airvo, and he removes his nasal cannula oxygen. He has a single reading of 5 on his EWS, but the remainder of his scores are stable at 4. But what his family describe is very telling. They describe a man who is increasingly confused. He is shaking. He has mottled purple skin. They describe that his legs are blue and cold to the touch. They pick up that he's drenched in perspiration, and his urine output has reduced because they've looked at his catheter bag and the urine is very dark in colour. And they repeatedly request that Mark is reviewed by a medical clinician. He has a medical review by a very junior member of the medical team, and this clinician does what you expect them to do. They see that the patient is stable because the EWS is stable. They take some bloods, the lactate's 2.4. They're very junior. They don't really comprehend what's going on, and they don't escalate. The family persist. They ask for a further medical review. A senior medical review is arranged. The clinician says the EWS is stable. This person is absolutely fine. They don't have a temperature. They're not declining. This patient does not need any escalation of care. So the following day, Mark's primary team return. His EWS is 10. They recognise that he has pneumonia with sepsis. They escalate to the intensive care unit team, who attend immediately, stabilise Mark, and he remains on the ward because that is a decision that is taken by his family. He has a cardiac arrest and he dies later that evening. So this slide it's a little bit messy, but it's my depiction of Mark's patient journey. And it was actually something that I did in my notebook in preparation for meeting Mark's family, because I needed to answer for myself and to try and understand why this patient received excellent care and within 72 hours he received very poor care in the same institution. And in my role, my first day in the job, I knew this was one of my missions, that I needed to look at the factors within our hospital that I needed to drive to change with the support of my colleagues to reduce the likelihood of this happening to anybody else. And I shared this with Mark's family, and after our 2-hour meeting, they said to me that they hadn't expected such honesty. They thought that I would come and I would cover the back of the hospital. They did not expect me to describe in minute detail where I felt we had done well, but also where I felt we had failed. So you might think my brain is a little bit messy. It's actually not, because when I was tracking this at the time, in my mind I was looking at the anticipation, the recognition, the response, the escalation, the governance, and all of the things that I thought we needed to do better in. And what I'm going to show you over the next couple of slides are the actions that I drove, not alone, but with the remainder of my team in the hospital over the next number of years, so that I would hope that we will not be as frequently in the same place again. So one of the things that I have a complete bugbear about is clinical handover. And for that reason, I'm chair of the Clinical Handover Committee. And it's the key to anticipation. There were a couple of things that jumped out at me straight away. How could a patient move out from a high level of care to a ward and nobody be told that that patient was moving? How could that happen? Cues for caution. Equally, how could this patient not have any senior clinical review that weekend following discharge? So one of the first things that I set about was a negotiation with my ITU colleagues to use the ISBAR tool, so that now any patient who is discharged from a higher level of care out of hours is physically handed over to a member of the receiving team with an agreement that there will be a review, and we use the ISBAR tool. Now, it took a lot of work. Interestingly, the intensive care unit team felt that they had done a wonderful job of handing over, and yet I found multiple instances where people were moved out of the intensive care and high dependency out of hours, and the clinical team were unaware until the following Monday. Additionally, we formalised an electronic handover that is now part of phase 1 of our electronic patient records. So every single patient who requires a clinical review over the weekend is captured in a read-only database electronically. So there is always proof of requested review and proof that the review has taken place. And I can tell you that this has saved my bacon in the coroner's court on more than one occasion, when the coroner very perspicaciously has asked us, did that patient enter any list for review for the weekend? And we were able to show them our documentation. Additionally, it was clear to me that the manual version of the electronic warning score that we use is really heavily error-prone. When we look at our own audit data, at least 50% of the scores are wrong. So that means on 50% of scores, there is the potential to either under or overscore the patient. In most situations, we're underscoring our patients, which means a failure to recognise deterioration and a lost opportunity to escalate if that is required. So I'm very pleased to say that we were one of the few hospitals that were able to pilot the electronic vital signs project. Now, I am a little biased, I'm a nephrologist, so actually we chose the renal ward as the pilot site. The results have been incredible. There was a little bit of teething problem, and I should tell any of you who are about to embark on this that it isn't great when somebody deteriorates, when you need minute-to-minute monitoring of the patient, and we haven't got around that yet. But the Synchrify service that we have is amazing. But just to tell you what I do, when I go to do my ward round, Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, I sit down in the nurse's viewing station, and the first thing I do is I look at the EWS scores of all of my patients over the previous 24 hours, and I prioritise whom I need to see first as part of our safety huddle. You've already heard very eloquently about the evolution of the critical care outreach service in our hospital. I can claim absolutely no responsibility for this, apart from to say I was a complete pain in the ass, and I did not let it go until I knew we were going to have a 24-hour/7 service. And Patricia Morrison says I am the bane of her life. But I knew that if we had a responsive critical care outreach service, that patient would have been seen on multiple occasions because they would have triggered reviews. And if we move to a system where a family can request a review and that family asked for a review on multiple occasions, I would like to think of one of our 6 amazing critical care outreach nurses, of whom at least 3 are in the audience, would have seen that patient. In terms of sepsis recognition and management, it was quite clear that we entirely failed to recognise this patient's sepsis. So we did an awful lot of work on this in terms of recognition, escalation and response. ED sepsis trolleys, launch of the sepsis form, a full week devoted to sepsis, but more importantly, sepsis training. And I think somebody said you can't train people in isolation. You can't train nurses and doctors separately to look after the same cohort of patients. So one thing that we've done very well is we've done sepsis training for ED and the wards, but it's been multidisciplinary because that's how we work. Now, in terms of moving on to the crux of the issue, the real reason I'm here today is to talk to you about how some of those changes that I felt were essential were actually implemented within our hospital. And we've already been told that you need somebody at the helm driving the changes. So I may have been driving the changes, but I was really the thorn in the side of many other people in our hospital in terms of enabling people who already wanted to make these changes, So what I'm going to do over the next 1 to 2 slides is describe the hospital governance structure and where our department, Quality, Safety and Risk Management, which is a really small department, but where it sits within that governance structure. And I'm going to try and explain how the governance structure we have enabled us to identify all of the required actions from that patient's case and how we were, over time, able to affect those actions. So one of the things that I do is I chair the Serious Incident Management team. I really don't enjoy it. And it is, unfortunately, an opportunity to, again and again, see where we don't do well. But I have a very much a safety 2 focus when I'm looking at clinical incidents. And in most situations, it's system factors that are problematic. But what it allows us to do is to generate smart recommendations that I can then force my colleagues within the hospital to implement because they come from the Serious Incident Management team. I'm involved heavily in the simulation committee, and that's chaired by one of our ED consultants. We're very hopeful that we're going to have a formal simulation suite set up within the hospital for multidisciplinary training. But we were able to identify training priorities, including sepsis and recognition of the deteriorating patient. Through chairing the clinical handover committee, I was able to direct the development of the ISBAR tool for handing patients over at transitions of care. Through chairing the sepsis committee and our involvement, we were able to direct around sepsis simulation, sepsis audits, and the pilot of the sepsis trolley. And probably the most important committee that we're involved with is the mortality committee, which ultimately reviews all of our hospital level data in terms of our cardiac arrests, because actually we do look at our cardiac arrest data and we do drill down into our unexpected cardiac arrests. Our ERT, EWS audits, and one of our previous ERT coordinators is in the audience. I'm happy to say that I've poached her to our department. We look very closely at our NOC and NAM mortality data and our ITU audits. And you can see that our EWS steering group feed directly into this committee, as does the resuscitation committee. So this is very much the governance structure that I think that you had described, which I have to say evolved entirely by accident and not by intention. But what you can see at the top of the slide, and what I think for me is probably the most important factor, is the need for senior clinical leadership. Now, that leadership does not have to be medical leadership, but it has to be clinical, because people trust the voice of the clinician. We have a really central patient safety and outcomes focus. And most importantly, what you can see from the next slide is that our committees report directly into the executive management team and directly through the QSRM board committee into the hospital board. And that is the level of governance that you need if you are serious about improving the lot of the deteriorating patient. Now, for my final, I haven't seen the 5-minute slide. No? Am I okay? Okay, right. So for my final couple of minutes, and you will see I have borrowed some of these slides, and I've already congratulated Nigel in particular on the piece of work that I'm about to show you next. So the next thing that I want to talk to you about is the system-wide approach and how we're going to take some of the hospital structures and the hospital learning and make our system better. And I've quoted recommendation 41 from iNews 2, and just to say to you that I don't really like speaking in public, and Maria Donnelly was supposed to give this talk today, and I'm really slightly peeved that I'm here instead of her, and so she has given me some of the next slides. One of the things that struck me when I was thinking about the deteriorating patient is that surely the key metric that we need to be measuring is the unexpected cardiac arrest. Because to my mind, there is no such thing as the unexpected cardiac arrest. It is the end pathway in most cases of the deteriorating patient. And if we look at the cues and if we follow our track and trigger systems, then really it is the minority of patients who have unexpected cardiac arrests. So if we're really serious about measuring the lot of the deteriorating patient, if we're really serious about seeing if we are doing better, then I hope all of you will agree and will really canvass for NOCA to support the development of the Irish National Cardiac Arrest Audit. And I am telling you now, I have shamelessly pilfered these slides from Nigel, and I feel quite bad about it because I'd never met him in his consultant guise, but he does tell me that he was a registrar in the emergency department in Tallaght. We have met previously, so please forgive me. So just to remind everybody, and actually it's at the front of the podium as well, Patient Safety Strategy to 2019-2024, really, really big focus on care of the deteriorating patient. Now this is where I wish my eyesight was a little bit better, but I've actually circled 4 sections in terms of patient safety improvement priorities. First one, the recognition of the deteriorating patient. Second, recognition and response to patients with sepsis. Third, ensuring, I'm really sorry actually. Ensuring safe, I'm so sorry, this is old age. Ensuring safe practice of care, and then finally, improving safety at transitions of care. I think I'm giving my age away here, so my apologies. So I read this again for a 3rd time last night. Just to remind you, my name appears absolutely nowhere on the slide because I had nothing to do with it, but I thought it was an absolutely incredible piece of work. Essentially, it was a scoping exercise carried out by NOCA and DPIP with Nigel and other people involved. And really, what they wanted to do was look at a feasibility study to identify options for national clinical audit of the recognition and response to the deteriorating patient. And I have to say, it's a long time since I have read such a high-quality review. The academic content was incredible. So I'm just going to quote you the 3 salient findings. The first salient finding was that at present, in Ireland, there is no data set that we use that fully captures every component of the early warning system across the entire patient journey. So that means that at the present time, it would be very difficult for us to benchmark either at a local hospital level or at a national level. The second finding, and this was supported by review of audits, both one in Ireland and multiple across other jurisdictions, was the inadequate and variable rates of compliance with the EWS guidelines. And I think it's really safe to say that EWS score completion and accuracy, and actually the timing of EWS, is problematic anywhere between 25% and 70% of the time. And I think I want to make a plug here for electronic vital score systems. You cannot reliably escalate a patient if you are relying on somebody adding up numbers and making mistakes with numbers. If you are relying on somebody to know when they should next carry out a set of observations. And one of the reasons why I really like the electronic vital system that we use at the moment is that there's a clock on it that tells the nursing staff when the next set of observations are due. And then finally, they recognise that clinical audit pathways in regards to effectiveness of our iNews system, they are feasible based on the international literature, and they would propose that we consider one of two audits. A no-brainer would be the in-hospital unanticipated or unexpected cardiac arrest, and then secondly, to give consideration to the unplanned ICU admission. So this slide, again, I've taken from the review, and what it identifies are iNews system with data acquisition points. And what I've circled is the afferent limb, which is actually the only component that we reliably catch data from at the moment. So this is a very modest amount of data. So if we take this a little bit further, there were 3 recommendations from this feasibility study, and I would certainly personally endorse all of them. The first one is that we should develop a national clinical audit of in-hospital unexpected or unanticipated cardiac arrest. The second one is that we should consider enhanced reporting from the Irish National Audit of Intensive Care, specifically in regards deteriorating patients in the 24 hours prior to admission to ITU, and specifically around unplanned admissions to ITU. And finally, we should promote existing and emerging data collections to drive quality improvement. Okay, so you've already seen this slide, but again, I do want to talk to you about some costings. So it's anticipated from the review and the feasibility study that to carry out a national cardiac arrest audit in Ireland would cost shy of 300,000 euros a year. Now, this is a very small amount of money when you look at the potential benefits that Nigel has already outlined. A 6.4% reduction in unanticipated cardiac arrests in Irish hospitals if you extrapolate the UK data. Increased hospital survival after discharge of 5%. And then the consideration of introduction of strategies such as respect in terms of more timely discussions with our patients about what their wishes are about their ceilings of care. And in terms of, this is my final slide, I have 1 minute remaining, so that this is and the reason I'm actually closing with this slide is that it was very disappointing to me that this audit, whilst it was accepted as an audit that should be performed, that no funding was made available for this audit. So if there is one message that I want you to take away today, if we do this audit, apart from the fact that the quality of care that our patients receive will improve, we will actually save money for the health service. And the final slide actually identifies the very significant financial savings that could be made if we were to introduce this audit. We're talking about healthcare workers' time. We're talking about improved efficiency of ICU bed utilisation because fewer patients will be admitted to the intensive care unit. We're talking about patients leaving hospital more quickly because there's less chance of them deteriorating in an unanticipated fashion. So my closing comment, I don't have a closing slide, my closing comment is that I've shared with you a very personal experience, a patient story. My first day in my job as Director of Quality, Safety and Risk Management, I felt a huge level of responsibility to that family. I felt that I needed, with our team, to give them commitments that we would deliver on the actions that I identified as essential during that meeting. And I suppose I've come 360 degrees in terms of looking at the hospital approach, but then also the need to look at a national approach. And if there is one thing I'd like everybody in the room to tweet afterwards, I'd like you to say, please vote with your hands in your feet to fund a cardiac arrest audit for Ireland, because the groundwork is done. Thank you very much.
Catherine. I suppose it's fair to say we were all really disappointed that it wasn't actually funded. And I think Orla I wasn't here this morning, but I think certainly Orla spoke about it this morning, I believe. Am I correct in saying that? And gave her full support. So, and I suppose the other bit is we have a national steering group now for oversight of clinical audit at the HSE. And again, like, I'm on that committee, and I'm at the moment the lead for the National Centre for Clinical Audit at the moment. So we're doing our best to try and put forward all the important areas for audit that we can. So certainly we'll be supporting you in as much as we can in that regard. So we've an address from Dr. Colm Henry next. I think it's sound but no picture, isn't that it? We have a photo. We have we not got a? Oh, you have sound. Oh, yeah, that's what I was thinking. So that's our last piece. So I don't know, whoever is going to put that on, they might do it for us, please.
Hello, and thank you for the invitation to speak at the annual conference. I'm sorry I can't be there with you in reality, although I am clearly virtually. So I just want to acknowledge the huge work of Aveline and her team in getting this programme. It's such an important part of our patient safety programme to this stage of evolution. Today we spent most of the day discussing the reconfiguration of hospitals, the Model 2 Hospital, One Flicker Hospital, Navan Hospital, and this could never safely have been done in all those hospital reconfigurations happened without the work of Aveline and the supporting programmes, critical care programme under Michael Power, Gary Courtney, acute medical programme, medicine programme, Jerry McCarthy, EMP, and of course sepsis programme. It's become a fundamental patient safety weapon for us in the HSE, and it's enabled us to provide safer services and also to reconfigure services. And I just want to acknowledge the huge work done by the team over the past few years. This programme, the National Deteriorating Recognition and Response Programme, was established in May 2017 by Aveline. 3 work streams established: education, such an important part of this. It's a continuous process, clearly not just educating the existing workforce, but those coming along, service improvement and guideline development. And as I mentioned, a critical part, a really important part of all their work to date has been the work of this programme with other national clinical programmes, allowing us to integrate what it was initially a patient safety proposal to something that's now ingrained in the way hospitals work, and now is entering a digital phase where hospitals such as Cavan has become part of the way care is delivered and where patients are tracked. Looking overall at the patient safety strategy in the HSE, there is a big commitment by the HSE, the board of the HSE, to the patient safety strategy 2019-2024, and improving the care and the services to clinically deteriorating patients is specifically identified as one of those critical patient safety priorities in this strategy. And as is detailed in this slide, clinical audit is such an important part, not just in terms of the way we all track our individual practices. It's a requirement for all doctors, for example, under medical council registration, but it's such an important part of that cycle of improvement that all healthcare institutions, all departments, and all services should have as part of their work. And I'm happy to say through my office, we set up the National Office of Clinical Audit to work with NOCA, and also to work very closely with existing patient safety programs, such as this early warning system, which has now become, as I said, part of the landscape of healthcare delivery in Ireland. In addition, the corporate plan for the HSE 2021-2024 places patient experience and engagement at the centre, and the work of iNews has recognised that family patient concerns an important safety indicator, and the patient and service users had been active participants in the revision of iNews, an important part of our work. The programme in support of the DOH National Clinical Effectiveness Committee, that's NCEC guideline, developed a systematic approach to the implementation of early warning scores in this iteration in V2. And that includes the following areas: anticipation, recognition and response. And the anticipation involves building on that culture of safety awareness, introducing concepts such as safety huddles, situation awareness for everybody. And we worked closely in collaboration with the RCPI to promote this kind of cultural shift and thinking among our frontline colleagues. Secondly, recognition. That's where the iNews track and trigger tool has been such an important enabling function for all of us. And of course, as I mentioned already, the introduction of a digital version of the project running to place this in a single ward, 20 acute hospitals, and a Cavan Hospital has introduced this to all wards in the hospital. And finally, response. The response, always the anticipation, the recognition, the measuring is only as good as the appropriate response that follows. And a really important part of this programme has been the appointment to the development of advanced nurse practitioners working with the critical care programme. We've seen the appointment of 47 ANPs into acute hospitals in the past 2.5 years. And there have been real benefits and to the way we have enabled staff and led out of this on the ground in terms of some of the metrics and some of the audits that have been carried out since, which I'll describe shortly. Governance is really important here. We need ownership locally. It can't just be an agenda item on existing structures. So what we want to get to is a place where there's deteriorating patient governance groups in hospitals whose function is and whose responsibility is to audit and review data such as in-hospital cardiac arrest data and unplanned admissions to ICU, and use these metrics to enter that continuous cycle of measuring and improvement that we see in the best of audit cycles. Deteriorating patients, of course, has been identified as one of the key risks recently by HICWA, and the State Claims Agency have also recommended improvements in recognition of clinically deteriorated patients. And we keep the National Patient Safety Office in the DOH regularly appraised of our own progress in implementing against our own guidelines. The revision of iNews, published in September 2020 in the middle of that pandemic, very heavily lent into clinical leaders in its development as our acute hospitals. It develops clinical leadership through a safe program, situation awareness for everybody in collaboration, as I said already, with RCPI, OMNSD, and through that building that culture of safety and awareness at ward level. The program led by Aveline used this approach, progressing improvement in the adoption of iNews and the partnership between the program and NQPSD have showed the benefits of that QI approach in terms of learning enabling development and upon deteriorating measure of deterioration in patients, so that we can keep patients safer, avoid unnecessary cardiac arrests, and avoid unplanned admissions to intensive care units. And that's where the full impact of education and training of our clinical workforce is so important. I mentioned already at the beginning the important working relationships Aveline and her team have developed with the critical care programme. Such an important part of getting to the position we are today. And also during the pandemic, we saw a revision of the cardiac arrest guidance and guidance for the role of respiratory sense and staff, and listening to staff and enabling them was such an important part of designing testing, training, and the scale up of our national contact management programme. And I just want to again acknowledge the work that was done during the pandemic in harnessing all the experience and expertise with early warning scores and ensuring their implementation. Right across hospitals, what was a very volatile and in whom rapid deterioration became an early feature of COVID-19, at least the first stage of the pandemic. So we've seen successful outcomes in terms of the outputs in acute hospitals, the decline in the rate of in-hospital cardiopulmonary arrests. We've seen reduction in unplanned admissions to ICU, and clearly we're looking for other gains too in those admitted unwell to ICU. Early recognition response may well yield a reduction in other metrics such as the number of patients with acute kidney injury with 24 hours to ICU, and a reduction in the length of stay in ICU and readmission post-discharge. So the ambition of this programme is second to none. We've already seen, as I said, direct benefits for patients in terms of arrests on planned ICU admissions, and I expect we're going to see further when they become critically unwell. So I'd like again to acknowledge the work of Aveline and her team, to Ger Shaw and the nursing community, to Orla Healy and to all those clinical programmes. This has been such a wonderful example to be involved with, to observe over the years its evolution from what was a QI education awareness to something that is now part of the fabric of our hospitals and enables us, such days like this, to make the argument for reconfiguration of hospitals all the more stronger, when we can lean into patient safety strategies and capabilities such as these, which our staff can use to identify patients before they become critically unwell and ensure that they're transferred to a suitable hospital in the case of Model 2 hospitals, or to ensure that the deterioration is checked at the appropriate time and getting the right expertise in, and to ensure patients don't deteriorate any further. So thank you again, and I wish you all best luck with the rest of the conference today. Thank you very much.
Oh, yeah. So, look, if anybody's any question, you're probably all tired. It's been a very full day, a wonderful day. But, look, if you have any questions, there's a few mics going around there if you want to address any of the speakers. And I know Evelyn wants to say goodbye to you, but she won't. I know people are going for trains and different things.
Hi, Aveline. I'm Colette Tully. I'm the Executive Director of NOCA, and I just want to say that NOCA absolutely fully supports the in-hospital cardiac arrest audit, and we worked very closely with Aveline and with Nigel as well, and I suppose we pushed it as much as we could to get funding, but we're not giving up, and we're back in again this year with the hope that we will get that funding. We're ready to go if we do. And if anybody knows anyone in the department who makes these decisions about money, if you're here, I think that's the place to go, because, you know, Maria and Orla and their team, they're trying to get this funded as well. So we just keep going, don't we? So well done, Aveline.
Thanks.
Hi, Aveline. I just want to congratulate you on today's really fantastic day. But it's not a question as such, it's just a point. I think you've seen through the themes of all the talks today was, the importance of the tool, the iNews tool. That's a paper-based system now. We need to be looking at moving towards a digital system right across our organisation. And Catherine, you pointed out very well, that takes planning and resources and investment to do that. Because we can't expect our clinicians and staff to use a tool that's prone to errors. It's no fault enemy. It's common knowledge that it's such a paper-based system is open to errors. So we need to move to the next level and think of a strategy behind of securing the funding and investment. Because this isn't an expensive project to roll out nationally, so it will take planning and investment over a 3, 4, 5 year period. So I think that's important. Like all through the presentation about iNews, I would like to see that be mentioned as digital iNews for the future.
Okay, thanks, Ronnie. Is that it? Okay, Evelyn, I'll hand over to you. Thank you very much for your attention this afternoon.
Just in response to Ronnie there, no better woman to come up with a strategy. I won't delay you very long. I just want to really thank Maria for chairing this afternoon's session. And as Maria said, we've worked quite closely, and she's been a great supporter of the programme, and I do appreciate her time here today. I just want to let you know that we are trending number 2 on Twitter in the whole of Ireland. So well done to all of you tweeters. I'd like to remind you that the QR code, in terms of evaluating today, we're not asking about room or food or any of that. What we really want to know is, what you liked about today in terms of the content. We do have another conference planned in Dublin Castle. We expect a bigger audience. So everybody online, you can come to Dublin Castle as well. And we'd really like to know what you'd like to hear about at that conference, because this is your conference. It's not mine. It's not DPIP's. You know, it's not anybody here on stage, it's what you want to hear in the services, what will help you progress and what is it that you want to know. So I'd really appreciate your time in doing that, and if you can't get to do the QR code, maybe you drop us an email, you know, aveline.casey1@hsc.ie, and absolutely we will take that on board. So they're just some two important things I want to say. I suppose today, and I'm conscious that you're tired, we heard from Orla and we heard her talk about no system can function without its cells. So we're all cells here and we're all part of the system, and you know, we're all what makes it function, and all our roles are vital. Dorothy talked to us about psychological safety and how it flattens hierarchy. You know, and that's a really important message, and that really, you know, in terms of patient safety, that really we need to move on with safety huddles. And if you bring any message away from today, I really believe the safety huddles will actually create a whole momentum around safety and providing better quality care to our patients. Sue, Liz, Christine, Yvonne, Mary, all fantastic. I think it's just amazing to see dynamic nurse leaders up here on the stage telling us how they're doing their business. I think that's just fabulous. Jerry then and Natasha, again, what a fantastic seeing them too. Well done, Natasha. Your energy was just exploding. And Jerry, biomechanical engineering. Yeah, telling you. This programme is all-inclusive. So, I mean, it's just fantastic to hear. And Gregor from Scotland, I mean, what a fantastic presentation, what an honest reflection of what's happening, acknowledging some of the good that we have here and also sharing where they are. And we all heard the message, audit, audit, audit. So we get it, we hear that. And I really liked his heal the sick, comfort the ill, but don't get the two mixed up. So it was quite nice. I think Nigel will be robbing that there now. And Derek, I mean, what a legend. If you knew the half, yeah. The work that he did during COVID in terms of critical care was just phenomenal. And he drove the critical care outreach all through that crisis. So, I mean, can't be underestimated. I think absolutely fabulous. Always a pleasure to work with. And one of the things he said to me way back, he said, we need to change all this. Everybody comes running when you're dead. You know, isn't it true? So we're moving away from it. And Ethna, candidate AMP, she's well on the road to being AMP, well on the road, and fantastic service, brilliant. Chris, I mean, what can you say about Chris? I do know he's so long, but so many gems within his presentation. There are so many absolute gems. Talking about reliability, that's where we want to get to. We want to rule out variation. We want to get our digital INU so we have a really reliable system that our staff are working with that supports them. Predictability. Look at the opportunities that we'll have to use the data and intelligence from that system to predict what's going to happen to our patients. Wouldn't that be amazing? Do you know, wouldn't that be just really on the out there in terms of patient safety and quality? And evaluation. Let's not forget our evaluation, because the first parts don't work unless we get the evaluation. And the dark matter of harm. I love that. I love that phrase. It's brilliant. So, I mean, just fantastic. Then Nigel and Connor, you know, with the work that they're doing in Respect. And Jerry McCarthy sent me a text to say he had joined, but he had to leave. So I just went back and said, I did get an ED consultant up on the stage. So he said, well done to Nigel. That's just an ongoing kind of joke between us. But fantastic. And then Catherine, you know, bringing a patient story and her very real experience. And in terms of governance, sometimes we look and we think governance happens up there and it's nothing to do with us. But that was a really live story about governance in one of our hospitals, what's actually happening and the difference that it can make. And I think that's just fantastic. And we're so privileged to be able to hear that and hear such an honest reflection. And I thank Catherine for that. And a very happy anniversary to you. It was mine last week. But I was 35 years married. And then Patricia Hughes, and Patricia is gone from us now, but then to bring HICWA, who I know are a regulatory body, but isn't it fantastic to see that they are now looking at deteriorating patient? This reposition. So when somebody earlier talked about people weren't taking it seriously, I tell you, when HICWA comes knocking at that door, you'll be way up there, so you will. So, you know, I mean, it isn't the right way to do things. We should all be working together. But you know what? It is an enabler too. It is a driver, and we'll use all the drivers we can get. I just want to finish by thanking, in particular, Blanett, the programme manager, who has done a phenomenal job. I really like you all to put your hands together, give her a round of applause. We had, I think, over 180 people in the room. We had, at 7 o'clock this morning, we had 235, and we're trending #2 on Twitter. What more could you ask for? I wish you all happiness, joy, and continue on your improvement journey. Thank you for coming.